Welcome to the brave souls who, despite COVID, showed up in person, and to everyone who's live streaming. I think in the post-COVID world, we've all become accustomed to staying at home with our slippers and our cup of coffee, but it's wonderful to see parents here. And to all of you out there, we're delighted that you're joining us this morning. We have a lot to cover, but first a couple of ground rules. The check-in and the password, I think you all have that because you're already online. And the questions, we're going to be happy to field. We have a big Q&A session at the end of the first segment and then at the end of the second segment this morning. So please submit your questions. We hopefully will get to all of them, and we really care about hearing what your questions are. So this morning's presenters, myself, I'm Jane Burns, and I'm the director of the Kawasaki Disease Research Center. Jonathan Lamb is one of our bioinformatics team, and we're excited to have him joining us to tell us about the diagnostic test for Kawasaki disease, which we've all been waiting for. Dr. Tremoulet is the associate director of the research center, and you all know her from clinic and her amazing work as a clinical trialist who's brought us new treatments for Kawasaki disease. Kristen Drummer is one of the newer members of our team, Pediatric Cardiology, and she's involved in all the management and care of our children with aneurysms. And finally, Lori Daniels is going to be joining us later this morning, and she's the director of our adult Kawasaki disease program, which involves both research as well as clinical care. So we're delighted to have the team here. I think you've seen the agenda, so we're just going to go through it, and at 10 o'clock we'll be having the questions. So please start posting your questions for us so that we can make sure and get them all answered. And there'll be refreshments for the intimate group that are here at 10:15, and then we'll regroup at 10:45. So I'm going to give you an update about what happened with Kawasaki disease at Rady Children's Hospital. We serve a catchment area of about 4.5 million people, and it's been very busy with COVID, and then after COVID it's been very busy with all of the respiratory viruses that have come to attack us. The research efforts are really divided into clinical research, which has to do directly with patients, and then the bench research, which is what goes on in our laboratory here on the UCSD campus. We're going to be talking a little bit about both today. So this is the graph of what we typically see for Kawasaki disease at Rady Children's Hospital, and you can see that every year we see generally between 80 to 100 patients, new patients in the modern era, but something very dramatic happened during COVID, and we're going to talk more about that this morning. What did we learn about Kawasaki disease from the pandemic? First of all, we had a new disease, and a new disease paradigm really that had never been seen before on planet Earth, and that was called multi-system inflammatory syndrome in children, or MISC. And there were a lot of features that overlapped with Kawasaki disease, so right away our team was called into the fray, and our team actually pivoted, and in addition to Kawasaki disease, we took care of all of the MISC patients at Rady Children's Hospital, which was slightly over 100 patients. It's a rare disease, much more rare than Kawasaki disease, with about 9,000 cases on the CDC website right now and 73 deaths. But it does affect inflammation in the heart and was a very severe disease, and we're really glad that the numbers have tapered off. There are really important differences. These are not the same disease. Unfortunately, there's been a lot of confusing publication, and if you go online, I think you'll see a lot of confusion about the relationship between these two diseases, but they are distinct, they are different. Some of the features that make them different are shown on this slide here. With Kawasaki disease affecting younger children, they generally have the full criteria, which as parents you know all about. Gastrointestinal symptoms, meaning vomiting, abdominal pain that can be severe, is less common in Kawasaki disease. We have, because of the genetics of Kawasaki disease, Asian children are overrepresented in our Kawasaki disease cohort, but having said that, the largest number of the largest ethnic group that we'll take care of every year at Rady's are actually children of Hispanic or Latino descent, because we are an under 5 Latino majority population here in San Diego. While Kawasaki disease obviously has increased inflammation, the markers of inflammation in the blood in the MIS-C patients were much, much higher in general. And they often, at least at the beginning of the pandemic, presented in shock, which is a rare presentation, thankfully, for Kawasaki disease. And I think the most important differentiation is that although the literature is replete with, I think, mistaken publications about aneurysms in MIS-C, we actually think that most of those cases are misdiagnosed Kawasaki disease, which is sad. But clearly in Kawasaki disease, there can be damage to the arterial wall, and the immune system actually attacks all the way into the arterial wall, where in MIS-C, they might have some dilation of the coronaries, but not the damage that we see with KD. So how can we learn from this relationship? Well, first of all, there's a huge opportunity for new scientific understanding, which I think we've taken advantage of and learned a lot. So the triggers of the KD-like features that are shared are probably molecular pathways that are shared between Kawasaki disease and MIS-C. And it was an amazing opportunity to get some funding, which is always what drives research, to understand some of the mechanisms underlying the treatments that we use for both MIS-C and Kawasaki disease. So your children were treated with IVIG, and that is one of the mainstay therapies for MIS-C as well. So one of the real breakthroughs conceptually that happened during the pandemic was teaming up with Ben Croker, who's a neutrophil biologist. The neutrophils are one of the white cells that circulate that have a lot to do with inflammation. And what Pepe Zhu in his lab was able to show is that IVIG, which all your children received, actually directly kills cells that mediate the inflammation that we see in our patients. So this was an important breakthrough because ultimately someday we're hoping to replace IVIG. It's very expensive. Not all the children in the world can receive it because they live in resource-limited places. And so we really want to understand better how IVIG works. So ultimately someday we can replace it. But this was an important breakthrough in understanding for us. Another very interesting observation was made by our climate team, led by Professor Jen Burney here on the UCSD campus. At the time that the pandemic started, it happened that we were in the middle of a therapy trial where we were looking at infliximab. Some of your children may have received infliximab versus a second dose of IVIG, and this was a clinical trial for children who had recurrent fever after the initial treatment. And I was leading this study that was ongoing at 30 sites across the United States who were all collecting data about the number of Kawasaki patients that they had. And you may be surprised to learn that the Center for Disease Control has no prospective way of monitoring Kawasaki disease in this country. So we were able to do this because of these 30 sites spread, as you can see here, across the entire United States. And we could collect the data about the Kawasaki disease patients that they were seeing. So in 2018, a typical year, pre-pandemic, almost 900 cases, and again, pretty similar in 2019. And then look what happened. 2020, and here in San Diego, we could continue to collect data, and we saw a reduction by almost half of the number of cases of Kawasaki disease during the pandemic with all of the behaviors that were put in place, right? We had masking, we had school closure, we had social distancing, we were better about washing our hands. So the graphs here show this as well. And you see the typical national situation here, and then look what happened during the pandemic. That's 2020. And we continued to collect data, obviously, here in San Diego. And in 2021, you can see we were starting to recover the numbers as children went back to school, as there was more interaction. And we're going to talk about what those consequences might be. So at Rady Children's Hospital, shown here, in this graph is another way of understanding the quote-unquote recovery. So here's the black lines are 2022. So this is this year, data hot off the press, and you can see with these red lines that compared to the previous years here, we had a surge of Kawasaki disease in the middle of this summer, and it hasn't maintained. But usually September is a low month for Kawasaki disease anyway. There's a very clear seasonality, and it just happened that in 2019 there was an anomaly where we had a lot of Kawasaki disease patients for whatever reason, and our climate team is looking at that, and we're excited to really drill down on what was happening in the environment, what was happening with circulating respiratory viruses at that time. So we'll see what happens as the year progresses, but it seems as though Kawasaki disease is back. One of the other striking things that is a huge clue, and we just need to be smart enough to understand what these clues are trying to tell us, is that if you look at 2021 and you look across these age groups here, the typical situation that we saw over the last 20 years is shown in the light blue bars with some of the confidence intervals. And you can see that the very youngest babies under a year really didn't change that much during the pandemic. And what really changed were the school-age children. So there's something about exposure in the home, presumably, for the youngest babies. They weren't masked, right? You weren't putting masks on your infant. And interestingly, we've just returned from presenting at a meeting in Japan, and Japan saw exactly the same thing, and essentially every country in the world saw exactly the same decrease in Kawasaki disease numbers. So these are data from Japan showing previous years in these lines here, and here's what happened. They had a severe stay-at-home, shelter-in-place mandate, and then masking. And here's what happened to Kawasaki disease. Now, Japan is the country of highest incidence of Kawasaki disease in the world. And again, they saw the same thing with the age groups, that there was a decrease, but less of a decrease in the less than 12-month-olds. So these are our infants. And they had less of a decrease than the older children. So very stereotyped response being seen across all countries in the world that keep accurate statistics about Kawasaki disease. Here's what happened with respiratory viruses. And if you have children right now, they're probably all sick with colds because it seems that 100% of San Diego right now has a fever, and they're all trying to go to our emergency room. So the situation, I'll walk you through this graph. Kawasaki disease is shown here starting in 2018. So you can see that by these groups of months, the line of what was typical. Then we had the shelter in place with the pandemic, and KD obviously went down, but it didn't go to zero. In contrast, the respiratory viruses, which are this green line, we were in for we had a bad winter just prior to the pandemic. And then SARS-CoV-2 came along, and look what happened to the respiratory viruses. They literally went to zero. So all of the situation we had, they were gone. COVID, on the other hand, is shown here. So this line here is the common cold virus, which came back sooner than the other respiratory viruses. So respiratory viruses went to zero, but KD did not. Other things changed during the pandemic, and this is Los Angeles before the pandemic and Los Angeles after the pandemic. And I'm going to go over just a little bit so that I can share with you some of the other features that happened during this period. When we looked at census block groups, which you can think of like a neighborhood, and we looked at census block groups where there was a Kawasaki patient and there wasn't, and we divided it into these time frames for 2020, if there was a Kawasaki disease patient in your neighborhood, you still had a higher pollution index from basically transportation. So there's something about pollution and air pollution and Kawasaki disease that seems to be happening. So we learned from the pandemic that KD is airborne for sure. We knew that, or we thought we knew that, but certainly we saw that proven by this experiment of nature. KD was reduced by masking, school closures, social distancing, but younger children with exposure likely in the home did not change in terms of their numbers, and now KD is back. Respiratory viruses went to zero, but KD was only decreased by 50%, and there's a role for the pollution story that we're trying to unravel with our climate team. So this is our wonderful team that I have the privilege of working with at UCSD. It's a large group of people with many different backgrounds and many different talents, and all together we make up the Kawasaki Disease Research Center. So I'm going to turn it over now to our next speaker, who is going to be Jonathan Lamb. And Jonathan is currently a graduate student, but as an introduction, I want to say that I tried for 40 years to make a diagnostic test for Kawasaki disease. That's how long we've been chipping away at this. And we gave all of our huge database, to which you have all contributed, gave this over to Jonathan and his machine learning team, and in 2 months, they had a diagnostic test for Kawasaki disease. Take it away, Jonathan.
As Jane introduced me, my name is Jonathan Lamb. I'm a PhD student here at UC San Diego in the Department of Biomedical Informatics. And today I'm going to be talking to you about our diagnostic test titled KIDMATCH, which, in a brief description, is a clinical decision support tool for diagnosing both KD and MISC. So we developed this after, as Jane mentioned, during the pandemic, because emergency department physicians were having difficulty in discriminating not only these two diseases, but there's also other febrile illnesses, such as viral infections, where patients will present with a similar phenotype to Kawasaki disease, but they don't necessarily have Kawasaki disease. This discrimination is important because there are different treatments and different monitoring conditions that you need in the hospital, so it's appropriate and important to know what type of disease they have. So what this diagnostic test does is that it takes the numerical values from the lab results that are commonly taken at the admission during the emergency department, as well as results from the clinical physical exam, namely that the 5 Kawasaki disease clinical signs, you integrate that along with the lab results, you put it into the KIDMATCH algorithm, and then the output is a singular risk score that clinicians can use in their clinical decision-making process. In terms of what features we're using for KIDMATCH, as I mentioned, we're using the 5 clinical signs of Kawasaki disease. We're also using age because that is an important distinction in MISC versus KD patients, as well as the laboratory tests from 5 specific tests that are typically run during ED admission. The important part about these laboratory tests is that unlike IVIG or other specialized laboratory tests, these are rather routinely taken. So because we're using the results from these tests, we can dramatically reduce the amount of money that is spent to acquire the lab results that are necessary to arrive at a preliminary diagnosis, and hopefully are able to intervene earlier in the administration of IVIG if the patient has Kawasaki disease or is MISC. So in terms of the actual algorithm itself, it's a 2-stage algorithm. So a patient will present to the emergency department, and then they'll have the physical exam and laboratory results taken. Once those numbers are acquired, the first part of the algorithm will attempt to distinguish whether this patient has MISC or does not have MISC. And then once the algorithm figures out, okay, this patient is not likely at risk for MISC, we're going to further try to differentiate whether they have Kawasaki disease or whether they are a febrile control patient that we're denoting FC, which is basically a patient that does not have MISC or KD. So how do we develop such a model? In machine learning, a typical way to develop a model is to do something called cross-validation. What this basically does is that you basically acquire your patient data set, which you can think of as a singular block. Now what you want to do is that you want to make sure that your model will perform well across the entire data. So what you do is that you split the data apart. So you can think of a pizza. Okay, I'm going to take 4/5 of my pizza away for training my model, and I'm going to set aside 1/5 of the pizza for testing. So what you do is that you train your model on the 4/5 of the pizza. You find parameters that are fit your model to that 4/5 of the pizza, and then you run those parameters on the test data that you set aside that the model has never seen before. And you keep repeating this for, in our case, 10 times until you find a model and arrive at the parameters that you're going to use for final testing. So once you move all the way down, you do your 10 separate folds, you have a test data set that is external, that the model has never seen before, and ideally is at a site that is not where you acquired your training data. So you've developed your model, you have the parameters for the model, and then finally you use those parameters and see how well it does on an external test data set. So first I'm going to talk to you about the training of this model. So in terms of the patient data we used to train KIDMATCH, we used 775 Kawasaki disease patients and 673 febrile children from Rady Children's Hospital. In addition, we also acquired 135 MIC patients from Rady Children's, Connecticut Children's Hospital, and Children's Hospital Los Angeles. As I mentioned earlier, the method we're using to train our model is called tenfold cross-validation. And what you can see here is across both stages, and in our first stage, we're trying to discriminate the MISC patients from patients that do not have MISC, we have a very good accuracy of 96%. And when we look at stage 2, we have, when we're trying to discriminate the febrile children from Kawasaki disease, we have an accuracy of around 90.1%. In general, anything above 90% accuracy is very good, so we decided, okay, the parameters that we've trained look pretty good, so how will this perform on an external data set? So unfortunately, for our external data set, we weren't able to acquire all the necessary data, that is, acquire patient data from MISC, from febrile children, and from Kawasaki disease patients. However, we were able to acquire data from MISC patients, namely from Boston Children's Hospital, Children's National Hospital in Washington, D.C., and the CHARMS Consortium, which is a 14-hospital consortium denoted in this map here that essentially was submitting both laboratory data to this consortium, NIH-funded, to be able to aggregate data to aid in the diagnosis or characterization of MISC. And when we validated our algorithm on these MISC patients, it performed very well. So 93.8% of the CHARMS patients, 96% of the Boston patients, and 90% of the DC patients were correctly predicted. So now that we have our algorithm, we need to be able to deploy it in the clinic. So what we did is that we put our algorithm into a calculator at Rady Children's Hospital, where clinicians would manually enter in values on the left-hand side here. They would press a button to form a risk score, as well as a ranking of the features. Now, what this ranking does is basically tells you what laboratory results or clinical signs are most important in contributing to the risk score. And the idea is that not only do you have a number for clinicians, but you also have some context as to what features a clinician should be using when reaching their diagnosis. So in terms of the workflow at Rady Children's Hospital, what a clinician does is that they have an internal URL for KIDMATCH. They enter that into their computer, they launch the calculator, and then they look at the patient's electronic health record. They take the values that are supposed to be inputted into the calculator, they manually enter it in, and then they produce a risk score and the features. And the idea is that these two components combined are returned to the clinician, and then they use that along with other aspects that they've collected during their evaluation of the patient to decide whether a patient has Kawasaki disease, MISC, or does not have either of those diseases. So in terms of the timeline for developing this algorithm, as many of you know, COVID-19 was first identified in December 2019. MISC had a health advisory issued by the CDC in May 2020. And we've acquired data from May 2020 to June 2021. So that's the extent of our MIC training cohort. Fortunately, here at UCSD, we have a remarkable team who has developed a decades-old registry for Kawasaki disease in febrile children. So we were able to take that registry directly, combine it with our MIC data, and then finalize and lock our algorithm in September 2021. We spent then 4 months to develop the user interface and deploy it at Rady Children's Hospital. And ongoing work now includes trying to refine that user interface as well as to determine the effectiveness of the algorithm, validate it with more external data, and see if it actually makes a difference in terms of patient outcomes. So in terms of future directions in improving KIDMATCH, the main aspect here involves the use of manual data entry from clinicians. It's another tedious task that right now is actually not necessary. So we can use something called Fast Healthcare Interoperability Resources, abbreviated FHIR, to automatically load features from a patient's chart into the KIDMATCH calculator. Basically, what happens here is that whenever a lab result is entered into the EHR, there is a software way to pull that automatically without having a clinician enter it. And the idea here is that as soon as the lab result is entered into a patient's EHR, whenever you load the calculator, those values will automatically populate it into the calculator itself, saving clinicians minutes in terms of using this algorithm, and hopefully making that more widely used because it's simply easy to use in terms of clicking just one button. Another question you may have is that we've deployed this at Rady Children's Hospital, so when will KIDMATCH be available at my hospital that's not Rady Children's Hospital? Unfortunately, because KIDMATCH is used for clinical diagnosis, the FDA is involved in determining whether this is a safe and effective device. So what you have to do is that for these software diagnostic algorithms, you have to seek approval from the FDA under what we call a software as a medical device category. It's very similar to the development of a clinical drug or even the vaccine in that you have to show to the FDA, here's the evidence I've gathered to show that our algorithm or product or medical device is effective. They review it, and then they decide, okay, what you say is true and it is effective, and then they grant approval, and then you can deploy it at other hospitals. So right now, on the left-hand side of this flowchart here, it is available at Rady Children's Hospital under an IRB protocol. It is not FDA approved. We still need to gather more evidence to tell the FDA that yes, it is effective and it says what we says it does. So in order to do this, we actually have a UCSD startup called Hilsizio, where we've licensed the intellectual property from KIDMATCH to be able to send this to the FDA, because going through the FDA regulatory process does cost money. The idea in terms of the approval process is that, like the COVID vaccine, the Pfizer or Moderna, you do have to go through the same regulatory approval process, which is called the Emergency Use Authorization or EUA application. The reason why we can do this is that MIC is part of the diagnostic algorithm, and because it's a COVID-related disease, we can go under this pathway as opposed to a more traditional, what they call a 510K pathway, which may take 2 to 3 years for the FDA to review and reach a final decision. The idea is that once the FDA grants approval of KIDMATCH, then we can distribute it to other hospitals where clinicians outside of Rady's can use this software product. So as I mentioned, you can go through the EUA process. So the EUA starts with the declaration of a public health emergency, in this case COVID in 2020. And what you have to do in order to get your product approved is that you have to submit what is so-called a pre-EUA submission. Basically, here's the evidence we've gathered so far. What additional components do we need to meet the regulatory or evidence standard that you need for approval? So right now, we have already submitted our pre-EUA, but we got comments back from the FDA that essentially requested us to complete more validation. As I mentioned earlier, in terms of the external validation, we only have MISC patients. So we need to, as the FDA requested, acquire external data from both Kawasaki disease and febrile children in order to have a complete evidence base for our algorithm. The idea then is that once we acquire that evidence base, we can submit the actual EUA application, and then the FDA will somewhat quickly act on that once they've acknowledged receipt of that application. However, in terms of an actual timeline, we estimate that from today, it'll be at least a year before the decision is made, and there's no guarantee that the FDA will approve that decision. It also depends on whether the FDA will declare the end of the COVID emergency. In that case, we cannot go through this pathway, and it may take longer. Another question you may have is that how much will this test cost? Again, it costs money to develop the infrastructure to be able to deploy this at different hospitals, and it's also very difficult to ship this out. So one important part about looking at reimbursement is that these are pediatric patients. They are not covered by Medicare mostly. So pricing will be based on whatever private insurance policies are willing to cover. There's 2 different pricing models. There's a subscription where a hospital basically says, I like what KIDMATCH does. I believe it'll make a difference. We're going to pay a monthly fee. There's also a per use pricing model where basically you bill it once per patient. Unfortunately, there's no real equivalent to determining a price for a diagnostic algorithm because most software as a medical device products nowadays are subscription-based. They're intended for long-term monitoring or sustained stay monitoring in hospitals. But the intent is to make KIDMATCH the cost per patient comparable to the individual laboratory tests, such as a complete blood count or a comprehensive metabolic panel that is used. So it'll just be another test that's equivalent to what's already used and is relatively inexpensive. So in summary, we've developed a deep learning algorithm called KIDMATCH with over 90% accuracy in classifying external MISC patients and internal Kawasaki disease patients at Rady Children's Hospital. We deployed this diagnostic algorithm in the emergency department of Rady Children's Hospital to aid our frontline clinicians in the diagnosis of MIS-C, Kawasaki disease, and other similar febrile illnesses. And finally, even though it is deployed at Rady Children's Hospital, we need approval from the FDA to make this available at other hospitals in the United States. And with that, I'd like to acknowledge the team at my mentor, Shamim Namadi, as well as another wonderful research scientist in the lab, Supreet, members of the UCSD Kawasaki Disease Research Center, and all the funding sources that were used in this study. Thank you. Okay. I don't see the folder.
So our next speaker this morning is going to be Dr. Kristen Drummer, who many of you who have children with aneurysms have already met. We're delighted to have her as part of our team. And she's going to be talking about how we can actually look inside the patient and evaluate the aneurysms and the damage to the coronary arteries. Kristen.
Thank you. It's nice to be here today and talk about the heart in Kawasaki disease. Today I'm going to talk about the different kinds of imaging that a lot of you are familiar with based on what has happened for your kids in clinic and in the hospital over the years. So the complications related to Kawasaki disease, really the major complications have to do with the heart, and that is the reason for the mortality. And that is the reason why it's also important to diagnose Kawasaki disease in a timely fashion so that treatment can be initiated within 10 days of the illness. That's what decreases the risk of these long-term complications. And studies have shown that the risk is decreased from 25% down to 4% if patients can be treated appropriately. This is particularly important in our higher risk patient population, which includes young infants, people of Asian genetic backgrounds, people who have had late diagnoses and get treated outside the window of 10 days, and patients who come after the illness has self-resolved and never received treatment. So the coronary arteries are these small vessels that arise from the big vessel called the aorta. We always talk about the aorta like the candy cane vessel that brings the blood out to the body. And the coronaries are these small vessels that bring blood and nutrients to the heart muscle to nourish the heart muscle. Just like we have arteries that bring blood flow to all of our muscles in our body. The coronaries are the ones that when people have heart attacks, and that generally occurs with cholesterol and plaques and things like that we hear about in older people, these are the vessels that we're talking about. So they're very, very important vessels. There's one that arises on the left side of the patient's heart and then kind of splits into two different arteries called the left anterior descending artery, or we say LAD, and the circumflex, which wraps kind of behind the heart. There's also one that arises from the right side of the heart called the right coronary artery. And then there's a lot of branches that come off of all of these. And you'll hear us sometimes say, oh, your child has so many branches, it makes it complicated to measure it accurately. And this is, why, because a lot of the branches can kind of make it difficult to get accurate measurements. So what happens to the heart? Well, the most feared complication are aneurysms. And so you see in these vessels, the coronary vessels, these billowing areas of dilation, and those are discrete aneurysms. You can see they're quite different from the normal vessels. And that is really the biggest complication that we want to try and prevent. There also can be generalized inflammation. And so these are some of the patients that present with KD shock or Kawasaki disease shock syndrome. The heart, if we're looking at it from this is the outside to the inside, the heart has several layers, and any one of these layers can be inflamed in Kawasaki disease. So there's a sac that's outside the heart that kind of has two layers together. That's called the pericardium. That can become inflamed, and there can be fluid that accumulates in that sac. Then there's the heart muscle itself, which is this nice, healthy pink area. That can become inflamed, called myocarditis. And then there's a thin lining called the endocardium, and that can be inflamed. So this is another potential complication related to Kawasaki disease. Generally, it's acute. It happens kind of early, and then it resolves. And 5% of all Kawasaki patients present with shock, which is inflammation of the heart muscle that makes it weak. And typically that improves with our treatments. So you'll sometimes hear us talk about dilation or aneurysm, and are they the same or are they different? Technically speaking, dilation and aneurysm is kind of a spectrum of abnormalities. So here on the left, you'll see that this is if we were to kind of cut the coronary vessel and look at it inside. And so when we're measuring the diameter, we're measuring the internal lumen of the vessel. Vessels also have layers to their walls, but we are measuring the actual region where flow goes through the vessel. So that is an absolute dimension, which is measured in millimeters. And if you think about how small 1 millimeter is, there can be quite a bit of variation between observers reading echocardiograms with these millimeter measurements. And when you're small, like a small baby, small changes in absolute dimension can mean very big changes in z-scores. So what are z-scores? I think you've probably heard us talk about z-scores in your children, but z-scores are indexed to body surface area. So if we think about what is the average dimension for an average person of your child's body surface area, it's like an average of an average. The z-score is 0. That means you are smack dab in the middle of everybody your size for that vessel. If you fall in the positive z-score ranges, you're to the right of this bar. And a normal distribution of vessels is usually between +2 standard deviations above normal and -2 in terms of the smallest normal and the biggest normal. So dilation occurs when you're just above normal. So z-scores are +2 to +2.5. Once you get outside of the +2.5 range, it's felt that that can be labeled as aneurysms. Small aneurysms are up to z-scores of +5, medium aneurysms are up to z-scores of +10, and larger giant aneurysms are z-scores above 10. So it's a spectrum that kind of allows us to compare you to other patients that are the same size. That's what a z-score is. So echocardiography is the most commonly used imaging modality in patients. Echocardiography uses sound waves that produce a picture. It's non-invasive. It doesn't have any radiation exposure. We usually can accomplish it unsedated in patients that are over 3, but a lot of you have toddlers that have to come to clinic for sedated echoes, and that's because, again, we're measuring things that are very, very small. And if a patient is crying or screaming or the heart rate is fast, it makes it complicated and difficult, so we sedate those children to get accurate measurements. There are some limitations as the body changes and people develop muscle mass and fat tissue. It makes it harder to see these smaller structures. And so as we age, coronaries can be difficult to see. It's not perfect for looking at clot in the vessel, and it's not perfect for looking at narrowing, because again, you're talking about millimeter changes and flow that can be hard to make certain whether or not there's clot or narrowing. But it is the most common modality that we use, and you've probably all sat in dark rooms and watched images of your children's heart. And so this is a picture of the heart function that looks at how it squeezes. And I apologize, it's not playing again, but this is a normal squeeze of the heart. This picture on the left is imaging the coronaries. This is mostly looking at the right coronary artery, both by 2-dimension and with color. And then this is imaging the left. And you'll see these very small vessels, this red flow going here and this blue flow going down. That's what we're measuring when we're measuring the coronary arteries. So these are still frame images of dilated coronaries. So sometimes you'll hear us say it looks kind of like a hose, or it looks like a large roadway. These are vessels that are bigger than normal. And so we literally measure them with our calipers here. And these are vessels that measure on the order of 3 millimeters. So these are dilated coronaries, but you don't see that discrete narrowing or aneurysm. These are vessels in one of our patients with aneurysm. So this is that billowing that we saw before, and you see how it kind of has outpouching here. That's an aneurysm. Again, this is the left coronary, and this is very abnormal in appearance. It kind of gets big, and then it gets little, and then it gets big, and then it gets little. This is coronary aneurysms in a patient that had Kawasaki disease and despite therapy developed aneurysms. CT is a modality that we're using more frequently now because the newer age scanners have much less radiation exposure. So we didn't used to use it because it was quite a bit of radiation. But nowadays, these scanners and with the proper protocols, radiation is very, very low. So the CT scan combines a series of X-ray images and then kind of stacks it for us to be able to see very specific and small structures. It's fast, and it gives us a lot of information. It tends to be the gold standard, although in echo, sometimes you'll hear us say that the pictures by echo were better than CT, and that has to do with motion artifact, which is why we sometimes sedate babies and don't do CT scans as frequently when the kids have to be under anesthesia. The anesthesia is necessary because when you're acquiring images of the heart is beating. And so you want to acquire the images where it is the most still, which happens during a certain phase of the cardiac cycle. And when the patients, we do breath holds with anesthesia. So we ask the anesthesiologist to take a deep breath in, hold it, take a deep breath in, blow it out, hold it, don't take another breath. And so you want to have the lungs that are small and the heart that is easy to image. And so it's a very specific snapshot of the coronaries, which is why we only do CT scans when the kids have to be under anesthesia when we absolutely need them. But we are doing them more in our adolescent population to see the distal vessels around the heart and make sure that there has been remodeling or not, and we use it to look at our aneurysm patients. We're also using CT calcium scores. CT calcium score is another imaging technique that uses CT, and it looks at this bright region in the vessel walls that is basically calcium deposition. That can occur after scarring has taken place there, which is generally after inflammation has been there. So we're looking at CT calcium scores in our adolescent patients, which gives us a good idea of how well their vessels have remodeled. And calcium in the vessels, at least in adults, has been associated with things like heart attacks and strokes in the future, but it hasn't yet been studied in our Kawasaki population. So this is a normal coronary CT. So it's a very kind of small vessel that kind of gets smaller over the course of its traversing the heart, and it kind of starts out a little bit bigger, goes a little bit smaller. These are normal. This is a normal picture of a CT scan. This is an abnormal picture. So this is the right coronary where you see the blood flow and then it stops. And then you see this long segment where there is no flow. This is a chronic total occlusion in a patient that previously had an aneurysm there. Distally, or out in the heart, there is flow, and that's from little vessels that develop to bring blood flow there. The body is really quite magical in our and sometimes when these occlusions happen slowly, new vessels can form and get flow to some parts of the vessel. But this is a chronic total occlusion. On the this side of the image, you see these billowing areas or balloons. These are aneurysms that have persisted in the same patient. So aneurysms on the left, occlusion on the right. This is what we're looking for when we talk about narrowing. So there's this vessel that comes out of the heart, it's large, and then this particular vessel gets tiny, and then it gets large again. So this is what we're trying to see by the CT scan, narrowing, and then aneurysms that have persisted. So CT scan can give us really, really beautiful pictures and data. MRI uses radio waves and magnets to create pictures. It does not use radiation. It's safe. It is non-invasive, but it does require an IV for some contrast agents, and we're using MRI to look at scarring that may or may not have occurred in the acute phase of Kawasaki disease. So especially for the patients who present with KD shock, where we know that their heart muscle was weak, and there was swelling in their heart muscle, we want to see if as they age in adolescence and in adulthood, if there's areas of fibrosis or scar. And the only way to really detect that is by MRI. And hopefully we're going to get more and more specific protocols that allow us to see on a very, very small level the amount of scarring that may or may not have occurred. And we do have an MRI compatible bicycle. And so that is coming to be able to exercise our adolescents and see how their heart works. These are MRI pictures. They're also beautiful. You can sometimes see the coronaries nicely. This is normal heart muscle here that is dark. This is, again, normal heart muscle. We're looking for swelling in the heart muscle here called T1 mapping. And then this is a picture of abnormal heart muscle with scar, this white rim of scar that has occurred following inflammation years back. Stress echo is something that we use in patients with coronary abnormalities to make sure that the blood flow is coming to the heart muscle. You'll see somebody on a bicycle and then they hop off and then you look at their echocardiogram looking at the heart muscle. This is an important test that we also use. So to end, I just want to mention that we do risk stratify the patients based on what happens to their coronary vessels over time. And so you'll hear us talk about risk levels, and there are protocols and guidelines for how we follow patients that we try to standardize throughout time. So thank you for listening, and I'm happy to answer any questions at the end.
The next speaker this morning is going to be Audrey Tremoulet, who many of you have met in clinic, and she's going to be talking about the treatments on beyond IVIG, many of which have been actually piloted or first used here at Rady Children's Hospital. Audrey.
Thank you, Dr. Burns, and thank you all of you for your attention this morning. My task today is to tell you a little bit about the treatments that go beyond IVIG, but also to kind of show you some of the information about what we've learned about how IVIG works in addition to what Dr. Burns already shared. So we're all familiar with the standard treatment of giving IVIG as well as aspirin. But really, how does IVIG work? One of the things that we've learned is that IVIG works by really killing an inflammatory cell, which is very important in the inflammatory process in KD known as neutrophils. And Dr. Burns shared this data with you already, but you can see here, just to give you a little bit more information about the data itself, the different colors here. In blue, we have dead cells, dying cells, and then black, alive cells. Without IVIG, the neutrophils you can see are really alive. And then as you give IVIG, that population changes, and you have a rapid decrease in neutrophils. Neutrophils actually produce proteins that cause inflammation, and so it's a really key process. So this is actually really important to know, as for many years we haven't really understood how IVIG works. And this is just one of those mechanisms. The other mechanism is in collaboration with Dr. Alessandra Franco, who is an immunologist that studies T cells. And here you can see the process by which IVIG is actually processed in the body. So what happens is IVIG comes in and it's actually cut into pieces, and then it's actually presented to T cells in our bodies. The cells that process IVIG are called tolerogenic myeloid dendritic cells, and these are the cells that then cause downregulation of the inflammatory process, leading to release of things like interleukin-10, which are proteins and cytokines in our body that decrease inflammation. This is a really important process that we think is actually involved in why some children are resistant to IVIG, because this process does not work well. So we now know some more mechanisms by which IVIG works. But as we all know, IVIG may not be enough in many of our patients, and there are patients that show up with IVIG resistance, which means that despite getting IVIG, the fever persists even 36 hours after completion of IVIG. Or as Dr. Doomer shared with you, there are children that despite getting IVIG, even sometimes in a timely fashion within that first 10 days of the fever, develop coronary artery aneurysms. So what do we have for those children? So this is a statement from the American Heart Association that came out in 2017. This is really the guidelines that globally are used for the treatment and diagnosis of KD. And there was an important change that happened in those guidelines, and Dr. Burns was essential part of that team for writing these guidelines. And that was this very small statement in this very large paper, which was labeled Adjunctive Therapies for Primary Treatment. Patients believed to be at high risk for development of coronary artery aneurysms may benefit from primary adjunctive therapy. So basically, kids that are at high risk of having aneurysms need more than just IVIG. So I'm going to break this statement down to you into a couple of parts to explain what we have been doing to try to push this message forward. And I think if you take nothing more away from my talk today, it's that really initial aggressive therapy in this disease is the key to preventing a lot of the pathology that Dr. Doomer just shared with you. So who is at risk for quote-unquote development of a coronary artery aneurysm? So Dr. San, Mary Beth San at Boston Children's, our group collaborated with hers and led to the publication of a risk model that really is tried to help understand what are the risks for developing coronary artery aneurysms. And it turns out that a z-score greater than 2, and you just saw from Dr. Doomer that is within the dilated range. So if you have an initial echocardiogram that shows that your z-score is greater than 2, you're at risk for having that become worse. If you're an infant less than 6 months of age, if you're of Asian race, or if you have an elevated C-reactive protein, which is an inflammatory marker that we all commonly measure, and it's actually part of the diagnostic algorithm that Jonathan Lamb shared with you. So these are all risk factors, and there's actually now a risk score that has been developed, we like to call it the SON score, that by having this basic information from someone presenting initially to the hospital, you can tell from the get-go that this child needs more. So if a child comes in and they have a z-score greater than 2, that actually gives them 2 points, and then each of the other ones gives them 1 point. And if you have more than 3 points or more, you need more than just IVIG when you come in the door. And this is a big shift and change and message that we're trying to get out to folks that care for children for Kawasaki disease around the globe. A little bit more breakdown about these groups. So here's the relationship of age on coronary artery abnormalities in KD patients treated in the first 10 days. So here everything has been done correctly in terms of diagnosing the patient within those first 10 days, but you can see there's a real big difference between the graph here on the left at less than 6 months old and those that are greater than 6 months old. And I want you to focus on the difference between the green region and then this yellow going into pink and red. The yellow, pink, and red are the dilated aneurysmal patients. And you can see that even if you're treated with IVIG within the first 10 days of illness and you're less than 6 months of age, you have more than a 50% chance of having a coronary artery abnormality with just IVIG alone. Whereas compared to the older kids, that's actually that 25% risk. And the aneurysm rate is actually within the 5% range. So it's very important that infants get treated aggressively and not only early, and they need more than just IVIG as well. So this is a little bit about the information about relationship of ethnicity and race on coronary artery abnormalities. I mentioned that Asian children they have probably there's a genetic predisposition for having coronary artery abnormalities, and it's really well demonstrated from our data here using the same colors. And you can just compare the green across these. So here on your left, you have the Asian children, then black, Hispanic, and white. And you can see that if you're a child of Asian descent, you have more than a 50% chance of having coronary artery abnormalities. So you can quickly see how this adds up to the risk score and that there really needs to be additional intensification in many children, especially of the babies and of Asian race. So this is when Dr. Burns and I get the middle of the night call of a 6-month-old Filipino boy in our emergency room. Our red flag suddenly goes up, and we know that we need to be very careful and really consider how we're going to treat that child. So what are the options for quote-unquote adjunctive therapy? In the American Heart Association guidelines, they really give a laundry list. And a lot of the questions that we get asked is, well, what should we do? That is actually sometimes a regional decision. For those of you that are listening from Latin America, where I work a lot with Kawasaki disease, some treatments may not even be available for you, and so certain things may not be available in your pharmacy. And that may be also in a different area of the world. There may be other drugs that are available that may not be elsewhere. So I'm going to go through some of the latest data that we have in adjunctive therapies, but the list is actually longer than what I'm going to cover. I just want to cover some new data that we have. So I'm going to start with the drug infliximab, also known as Remicade. This is an antibody that you can see here. I mean, we did some work with Niels van de Castile, who's a pharmacologist, to really understand how this drug works. This drug gets used for a lot of different diseases, rheumatoid arthritis. It's used in children quite commonly with things like inflammatory bowel disease. But we wanted to use it a little bit differently. We give this as a single IV treatment. It's only given once, so that doesn't. So therefore, there's no inherent issues with immunosuppression that happens over prolonged use. So it's a very safe drug that's been demonstrated to be very safe in Kawasaki disease. This binds to a protein that's pro-inflammatory that's very high in Kawasaki disease patients, known as tumor necrosis factor alpha. So that's how it works, and it takes that out of the circulation, so you have less inflammation. And what we've discovered is the dose. So, one of the things that's important in pediatrics, and this is globally in medicine, is not just giving the right drug, but making sure you've got the right dose. And what Niels and his team were able to show us is that because we're also giving IVIG, and IVIG itself has a lot of antibodies in it, infliximab is actually, we need to give a higher dose of it in our patients than is usually given to children with most other diseases because of the combination of IVIG plus infliximab and the way that this particular protein is recycled. So we're trying to do our best to get the word out about not only having this as an option, but also making sure that children are getting 10 milligrams per kilo and getting this higher dose of infliximab. So now I'm going to talk a little bit about a recent trial that we did known as the KidCare trial. This was a Kawasaki disease comparative effectiveness trial that what we wanted to do was to understand if someone has KD, they get a single dose of IVIG, but yet then their fever recurs. Is it better to give them a second dose of IVIG or to give them a dose of the infliximab? We're fortunate to have collaborators around the U.S. that joined us in this effort. And the KidCare team, you can see here a lot of the sites. These were the same sites that then were able to pivot and provide data for the diagnostic tool development that Jonathan presented. And we had 30 sites across the U.S. And here's the flow of this study. So here you see that you got diagnosed with KD, you got IVIG. The child remained febrile 36 hours to 7 days after infusion, and then you either got a second dose of the IVIG or you got infliximab, and we looked at how you did with fever. If you continued to have fever and you initially got infliximab, then you got a second dose of IVIG. And the opposite was true. If you'd gotten a second dose of IVIG initially, then you went on to get infliximab if you had more fever. And then we looked at echocardiogram and CBC and C-reactive protein to see which of the groups did better. In conclusion, what we found is that treatment of IVIG-resistant patients with a 10 milligram per kilo dose of infliximab resulted in reduced need for additional therapy, so they had to have less crossover to get a second IVIG. These children had less anemia, and that's a really important point that we're also trying to get the message out that there's actually something called hemolytic anemia, where the antibodies are attacking your red blood cells and lead to anemia. This happens sometimes with increasing doses of IVIG. So there's a higher risk of having hemolytic anemia with a second IVIG than with infliximab. And then also giving infliximab led to shorter hospitalization. This is additional data that really shows how effective infliximab can be. But we do understand that there are parts of the globe where this is not a treatment option for them. But we wanted to make sure that we had data that really demonstrated not only the safety that we've had before, but also the efficacy of infliximab. So I saw as I was following along the chat that there was a question about anakinra, and I hope that this actually answers that question. So we did some recent work with anakinra, which is a medication that blocks one of the, I showed earlier, the neutrophils. They make a lot of IL-1 beta, interleukin-1 beta, and anakinra is a treatment that blocks that. So we studied the safety and the pharmacology of anakinra in patients with acute Kawasaki disease with coronary artery aneurysms. And the first thing that we did was to evaluate the safety of the drug, because although it's actually approved by the FDA down to basically birth for children with other diseases, it had not been studied in depth in Kawasaki disease. We did that, and gratefully we were able to demonstrate this is a very safe treatment. This treatment can be given in the hospital, and then within the context of this study was given up to 6 weeks afterwards to some children. This is actually a drug that is generally given by injection, subcutaneously, meaning just under the skin, which is, is difficult to do in little kids. It's painful initially also, although I have to say that for those families that are on the line that were part of the study, and a huge shout out to them and thank you, our parents are amazing, and we're able to give this drug to the children even at home subcutaneously. In this study, we actually also looked in the hospital at giving this drug IV. And you really sometimes don't even know the data you're generating till it becomes useful later. It turns out that this drug was used quite a bit globally for MIS-C that Dr. Burns spoke about initially, the post-COVID inflammatory syndrome. And the IV data that we generated in this Kawasaki study was actually really instrumental in being able to understand how to give this drug to our MIS-C patients around the globe. So we looked here at subcutaneous versus IV treatment. We enrolled 22 KD patients with aneurysms at Rady Children's Hospital and at Boston Children's Hospital. And we found out a lot about the way that the drug works. We were able to figure out that when you give the drug initially, there's a nice peak that comes up, and then over time, that drug level goes down. We were able to figure out the actual dose that we should be giving to children with anakinra treatment. Again, those are data that we actually also then ended up using for our MIS-C patients and really provided some guidance. So now this has become another treatment option, and there's data there that hopefully can be used globally. Many places around the globe depend on data being generated here in the U.S. in order to seek approval for that drug. A perfect example is the use of infliximab is actually now by the Ministry of Health in Japan is approved for the use in Kawasaki disease, and that's really based on our data and data by others. So this is important information about the use of anakinra. So I wanted to next shift to combination treatment for children with KD and coronary artery aneurysms. In a previous KD Symposium, we've talked about the use of atorvastatin, also known as Lipitor, which I always joke with our parents, maybe if you may have in your own medicine cabinet for your own cholesterol issues, that is not why we need to use it in Kawasaki disease. Atorvastatin, actually, the statins do a really good job at healing the endothelium, and that's that internal lining of the arteries that Dr. Doomer spoke with you about that are a key part of aneurysm formation. So we decided a few years back that we wanted to study the statins, atorvastatin specifically in KD. We demonstrated that was safe. We now have the FDA approval to go down to 1 year of age and using statins in our patients, and we're using those in the acute treatment of Kawasaki disease. And then for any of you parents that have children with ongoing aneurysms, you'll also know that we have we are now using atorvastatin in that population as well. This combination treatment then combined the data that we've had from statins along with anakinra. We've had 6 patients enrolled so far to date, and really here the question is looking at the safety and then getting samples from those patients to really look in the lab and to see how the endothelial cells are behaving It turns out that they're much happier with atorvastatin, and also inflammation is improving with both of these drugs. So that is more data that will be coming out from our center, and really gets to the point of having treatments that attack both what's happening at the level of the arteries as well as global inflammation in the blood. So with that, I just want to finish with just thanking especially our patients and your families. When you guys come to our emergency room, you're just looking for answers as to what your child has. And then I think there's a level of relief that happens when your child is, diagnosed with KD, although that brings on a lot of anxiety about understanding the coronary artery abnormalities. But it's really in the midst of all this that we're not only talking to you about KD, but we're saying, hey, would you mind giving a little extra blood and signing this consent form and being part of this study? And we're just eternally grateful to our families that really believe in what we're doing, and during that most vulnerable time are signing up for these studies, because these studies are really changing what happens globally. We were just in Japan at the All Japan KD meeting, and the data from here, again, are what really is changing what happens with KD, and the same thing with anakinra. It's very unlikely that some of these studies will actually happen in Japan and in other parts of the world, but this is changing how other governments, ministries of health, about how they really think about treatment in KD and what they permit to be, what they permit their children with Kawasaki disease to be treated with. So we're eternally grateful. As well as for the NIH and PCORI, the Patient-Centered Outcomes Research Institute, for their funding. So with that, I will conclude and just say thank you to all. I think now we are at the break point for our question and answer period. So I think that the Q&A will happen now for the next few minutes before we take a little break.
So I'm just going to triage, along with Dr. Tremoulet, these questions that have come to us from our audience here and from people online, and hand them to the appropriate person to answer the questions. So one of the questions is if we can expand on the idea of what a febrile control patient is, and what are some of the examples of the diagnosis of these patients. So we've learned over the years that when you want to make a diagnostic test, or when you want to compare what's happening in Kawasaki disease to other children who don't have Kawasaki disease, it's really not relevant to compare them to normal children who don't have fever and who are completely healthy. What you really want to do is understand the elements of what's different about a Kawasaki disease child with fever versus another child with fever who also has some level of inflammation and the things that fever causes. And that's the comparison that we want to make. So if you come into Rady Children's Hospital emergency room, and one of our team members there is on duty, which doesn't always happen, but it often happens because we have a wonderful cadre of physicians in the emergency room, and frankly, we can't do this research without them. And if your child has fever and one of the 5 criteria for Kawasaki disease, so that could be a big lymph node in the neck, it could be the bloodshot eyes, it could be a rash, or it could be some combination of those, or red lips, swollen hands and feet. If they have something that looks a little bit like Kawasaki disease, then that child will be offered enrollment as a member of this study. Sometimes it's because the physician is getting blood tests to actually rule out Kawasaki disease. Sometimes it's just because they want to get blood on this patient for the evaluation and management of that patient, but they qualify for the study. And so these blood samples become really, really important. And in fact, we collaborate with other institutions all over the United States who are doing testing of something else, maybe not even related to Kawasaki disease, but they need that comparison group, which is very, very hard to get. And it's only because we have this fabulous relationship with our emergency room doctors here who take the time to approach the parents, and we have wonderful parents who are willing to donate a little bit of their child's blood at the same time that blood's being drawn for standard of care. So it's a treasure trove of samples that fuel all of the research that we're doing. So thank you to all those non-Kawasaki disease patients out there in the universe who have participated in that research.
So there was a question about anakinra and its intended use and how it's administered and whether it can be used as a single dose treatment. One of the things that's important with all these drugs is to understand the properties of the drug. Anakinra actually disintegrates very quickly. And so it really only lasts a little while, less than a day in the body. And so sometimes in some patients it needs to be administered multiple times a day, which makes the IV dosing easier. In our study that we did, we gave it for about 2 to 6 weeks. And now our current use in the hospital for a child that's on anakinra will be to administer it during their hospitalization stay, which can be any number of days. Anakinra is, it's actually difficult to give it as an outpatient drug outside of the study that we did because of the lack of FDA approval specifically for KD. So we're now trying to find other drugs that work like anakinra but last longer in the body to see if that's an option to last a little bit longer and affect the inflammation. One question came, is the bivalent booster safe? This is, I'm assuming, for the COVID vaccine. We're scheduled in a couple of hours to receive one. First of all, congratulations to this family for signing up. Get in your car, don't let us be an impediment, go get your vaccine. We have some very nice data from our group that, in fact, the COVID vaccine is very safe in Kawasaki patients. We encourage you all to get it. We have treated 114 children with MIS-C at Rady Children's Hospital. They have all been unvaccinated against COVID. So the COVID vaccine in children really helps prevent MIS-C. So please go ahead and get vaccinated. And there was a question about lung effects in KD. Gratefully, that's not one of the organs that's majorly affected.
We've got some questions about long-term follow-up and adults after KD, and we're going to hold off on those until Dr. Lori Daniels joins us, and she'll be talking about that. That may answer some of your questions, but then we're going to have a second Q&A session after that. So we'll wait to answer those questions. So don't go away. We're going to answer them, but we'll let Dr. Daniels answer them. I'm going to turn it over to Dr. Doomer for some of the cardiac questions.
Okay, the first question is, what age is recommended for the calcium tests? So we use calcium tests in our adolescent and young adult population. So, it's mostly after a decade of Kawasaki disease. That's kind of the first reported time where you can see calcium deposition. So that whole process takes many, many, many years. And the most important people to get calcium tests really are the patients who had giant aneurysms or medium aneurysms. We haven't seen calcium buildup in the small aneurysms or even the transient dilation. So as we learn more about who to study, it makes more sense to do these CT calcium tests in patients who had significant coronary artery involvement, even if they remodeled. So we generally do those studies around 13 to 16 years of age as the first time, because the majority of these patients were young and had their Kawasaki disease more than 10 years ago. The other time a CT calcium test is important, which was another question here. It says, is it recommended to examine one that had Kawasaki disease over 10 years ago, now that testing and new data has developed, maybe information that was not there 10 years ago? So yes, if you're somebody who had Kawasaki disease and you're either not sure about the status of your coronary vessels, or you knew that your heart was not normal at one time but now is normal, any sort of history where you're not sure And we get these patients that show up, we automatically order a CT calcium score, because if your CT calcium score is negative and you're 15 or 20 or 25, then it's very unlikely that you had bad damage to your vessels. So a CT calcium score can be obtained with very low radiation. It doesn't show us the vessels in terms of how big are they, but it tells you if there's been calcium deposition, and that would be important to know if you're somebody who had it a long time ago or don't know about the status of your vessels. So that's another time where a CT calcium score is good to order. There's a question here that says, is there anyone I can contact by phone at a Boston hospital? KD patient. So there is a Kawasaki group at Boston Children's Hospital. Dr. Jane Newberger, Dr. Jane Burns, they're very good friends. So the two coasts are well covered with world experts. So there's a big team at Boston Children's Hospital. I'm not sure who they go to for their adult Kawasaki patients, but you could contact the Kawasaki team at Boston Children's Hospital, and that's under Dr. Jane Newberger. It's Newburger. So you can go through the computer and contact them. There has been news about COVID causing heart issues in people who had COVID. If a Kawasaki patient with no heart involvement had COVID, should they be checked or monitored for possible heart issues from COVID? What signs should they look for? This is a great question. COVID is obviously very prevalent, so it's quite possible that all of our children with Kawasaki disease will get COVID at some point, because it's probably not going away. COVID can cause heart inflammation in general. It doesn't seem to affect our Kawasaki patients any differently. In fact, we haven't had a Kawasaki patient at Rady's be admitted for COVID myocarditis or COVID inflammation in the heart. So COVID inflammation of the heart is a thing, but it doesn't seem to affect our Kawasaki children or young adults differently than the general population. What we do in pediatrics is that we see a lot of kids for history of COVID and then some symptom like fainting or shortness of breath or something like that. If your COVID illness was mild, meaning like you were able to stay home, you had a little fever, you had a little headache, you had a little cold, something like a very normal type of a viral illness, we don't screen any of those children, Kawasaki history or not. If your course was severe, like you needed to go to the emergency room, you were admitted to the hospital, you had a diagnosis of myocarditis, those patients are the patients that need to come back to cardiology. The patients who have heart inflammation from COVID present just like other viruses with inflammation. They present with crushing substernal chest pain, like in a 6-year-old or in a 10, something that's very abnormal. You wouldn't anticipate it during the acute illness. Those are the patients that need to be seen. So it's generally chest pain and fever that is out of proportion to any other virus that you've experienced in the past. Regardless of your Kawasaki history, those are the patients that need to be seen for COVID. How are occlusion aneurysms treated in adolescents? Great question. So in all of our patients that have persistent coronary aneurysms, they are all on anticoagulation. So if the vessels are very big and you still have giant or large aneurysms, then we always put you on an antiplatelet agent such as aspirin or Plavix, and we put most of our patients on apixaban, which is an oral medication that keeps the blood thin. So many places in the world use something like Coumadin, which is a blood thinner that we use for valve replacements and things like that. But we here use newer oral agents that keep the blood thin and don't require a lot of lab monitoring and things like that. So if you have large aneurysms, we treat you with antiplatelet agents, systemic anticoagulation, and atorvastatin to help the vessels be as healthy as they can be. That's what we do for those patients. Any updates on kids that took Lipitor with Kawasaki disease but had no aneurysms? Yeah, so that's an interesting question. There is this rare time where now that we're doing CT scans in adolescents, so for instance, like let's say you have a 15-year-old who had some heart involvement, but it got better and we think it's all remodeled. there's times where we bring those kids in for CT scans and find out that the vessels aren't quite normal. So the echo only really shows the very beginning part of the vessel, but in the CT scan, we get the benefit of seeing everything. And so there's times we've looked at the CT scan and been, you know what, like they don't look quite normal. They're just mildly dilated, or they're mildly kind of something we say ectatic, like the edges aren't very clear. We do put those patients on Lipitor, and we hope that over time that their vessels will become healthier, have the normal reactivity, and perhaps remodel a little bit. We don't have that data yet because now that we're using CT scans more frequently, hopefully we can get that data going forward. But we do tend to recommend Lipitor, and hopefully in the future we'll have better information about what happens.
So some treatment questions that came through. Why is infliximab given only once? So the way that we designed that initial study was based on the pharmacology of infliximab, which seems to last in the body somewhere between 3 to 5 weeks. So the thought initially, and that has really proven probably to be right, is that that's really the point in which we can make the most impact in terms of decreasing coronary artery inflammation, because most of that inflammation happens initially. We do not give a second dose of infliximab. I know that there was a family there that said that they did get a second treatment, and there may have been some issues with allergies. The issues with allergies do not happen with the single dose, but because this is an antibody, you can develop an allergy to that treatment, and that's well reported in other diseases where we give more than one dose. There's a question about doxycycline, which is actually an antibiotic, but has also been shown to have anti-inflammatory processes. There's an ongoing study in Hawaii that, as far as I know, was still enrolling and looking at also having decrease in inflammation using doxy in KD patients. But I do not believe that has actually finally been published. And then there was a question about mTOR inhibitors, which are used in all different kinds of diseases, but also, again, to attack the inflammatory process. There's a study out of Melbourne. Someone was asking, I believe, if we're doing any work here with that. I'm not aware of anything being done in the US, and I don't have a preprint. That same person actually also wrote about the long-term follow-up, and I think we're going to get to hold off on those until Dr. Daniels presents with the data for the adult study.
And I think I have the last question, which is with regards to the use of, well, there's one more after me. There's the use of ethnic data in the collection of the lab results for KIDMATCH as well as coronary artery diameter. So fortunately, we do collect that data, and we use that as part of something called sensitivity analysis, which is basically saying, is the performance replicated across different groups, or is there a difference in the performance of KIDMATCH on Asian populations versus, say, Latino or Black? So fortunately, with external validation of MIC patients, we have a diverse cohort in terms of patient population and ethnicity. Because, for example, here in San Diego, we have a predominantly Latino population who are diagnosed with KD, whereas, say, in Washington, D.C., they're predominantly Black. And what I can say is that there's no significant difference in ethnicity when we do evaluate this performance.
Moving into that same space of the diagnostic test, you've heard about Jonathan's KIDMATCH algorithm, and we call that a physician support tool, decision support tool, with the idea that it's not a diagnostic test, it's information that we think is going to help physicians decide to move in the direction of Kawasaki disease or MISC or not. We are working with Mike Levine's group at Imperial College. We have a fabulous ongoing collaboration that spans decades with that group, who are very, very active in Kawasaki disease research in the UK. And with them, we have come up with a series of RNA molecules. So these are things that can be measured, molecules that can be measured in the blood. And we came up with a panel of those. There are 13 of them, and this is published work. And now we've partnered with a company in the Netherlands who is doing additional work to decide whether or not to move forward with commercialization of that diagnostic test, which would be a blood test. It has to be adapted to the kind of blood test that a hospital laboratory could run, but now the engineers have basically figured that out. So the question is, how much benefit will that add to the kinds of things that we already have in hand to diagnose Kawasaki disease? So that is in the pipeline, and it is at the question of commercialization stage, so possibly close to coming out. And another question was about really the genetics that we're going to talk about in the second half of the session here this morning. So I'm going to hold off on the genetics question until after we have that talk.
Okay, I think I have a few more questions here to answer from the cardiac standpoint. So one of the questions was, are there any recurrences of Kawasaki disease aneurysms cases on adolescent stage of life? So typically, I'm not exactly sure how to interpret this question. I'm going to answer it both ways, potentially. So if you have an aneurysm and it has remodeled, we have not seen that then become an aneurysm again. So we have seen perhaps maybe it's not completely remodeled when we repeat CT scans in adolescents, but we don't all of a sudden see like new aneurysms. So in that sense, the aneurysms like don't recur if they've regressed before. The other interpretation of this question might be like, can the children get Kawasaki disease again in adolescence, I guess? And there is a recurrence rate of Kawasaki disease, meaning like you get treated, but then like maybe 6 or 8 weeks later or something, you kind of flare again or something like that. But that recurrence rate is very low. It doesn't tend to happen again in adolescence. And then there are other syndromes that can come after that, like febrile syndromes, which are really rare. But we don't generally see recurrences of Kawasaki disease in adolescence necessarily. Is that right? I'm asking the Kawasaki experts here. So then calcium buildup due to warfarin. What an amazing question. Okay. This is from somebody who evidently is quite astute. So calcium, long-term warfarin or Coumadin use in adults has been associated with systemic calcification. Yeah, so warfarin is, well, it's rat poison. Is that what you mean? Yeah, warfarin is rat poison. And warfarin is the generic term for Coumadin. Coumadin is the brand name. So many patients are on these medicines, like tens of hundreds of thousands, right? Because atrial fibrillation, valve replacements, there's lots of reasons to use warfarin in adults. And in children, we used to use warfarin, like that used to be the only way to thin the blood well enough when you had giant aneurysms. Or you could use a shot of Lovenox, which is heparin, but the shot has to be given twice a day. So that's why Dr. Burns and Dr. Tremoulet and their group moved towards these newer oral medications that you take by your mouth, like you crush a pill and put it in water or whatever. And amazingly here, I will say there are not that many patients with residual giant aneurysms. It really is a very small number of patients. Like we can count them on 2 hands, the number of patients that we follow in pediatrics with persistent aneurysms. I think that's a testament to how aggressive the therapy is up front, which is why we're trying to get the message out across the world and the country, right? Because even when you move slightly east of here anywhere, I don't know that the treatment is as aggressive. So in our persistent aneurysm patients, we don't use warfarin. So we don't see calcium buildup in our patients because we don't use it. But in all these other patients that are chronically on it for valve disorders and things like that, because I also follow kids with mechanical valves, we absolutely do see calcium buildup. And it can be impressive. You can do a chest x-ray on a 15-year-old who's been on Coumadin for 8 years, and their entire bronchial tree lights up with calcium. So there's a scientific reason why calcium builds up on patients with warfarin. That's like a whole other talk that we just gave in Japan, talking about why it's important to find alternatives to warfarin use, which is why we use these newer agents called DOACs, direct oral anticoagulants. And our research here in this country hopefully will help Japan and other Asian countries move towards not using warfarin because they have what seems like a very high number of adults who are getting calcium buildup in their vessels and dying of rupture of the calcium in their vessels. So we think this is a really important part of the therapy of Kawasaki disease, and we don't see calcium buildup because we don't use warfarin, but it is absolutely a thing and it's dangerous for vessels. And then the last question is it a regular CT or a 512 CT? I'm not exactly sure what 512 CT means, but if you go to get a CT calcium score, it is a different type of CT in terms of how they acquire the images than it is if you go for a CT angiogram. So they can use similar machines, but it's a different protocol. It's like a flash scan that just looks for calcium. So I don't know exactly, but it has to be ordered CT calcium score. So the physician ordering it has to write CT calcium score. I had Kawasaki disease at the age of 1. I have 1 giant aneurysm and I've been on medication since I am 15 now. What are the chances of required surgery, heart attack, et cetera, when I am older in my lifetime? That is a great question. The risk of heart attack is, it's there, obviously, if you have a giant aneurysm because the flow through it is different, but it's luckily very, very, very rare, particularly with proper medical therapy and proper counseling on what you can and can't do. So if you have a giant aneurysm and you're on all these medicines and you're worried about flow through your vessel, maybe you're not going to be a marathon runner, right? But we have ways of keeping people healthy that require long-term medications for this sort of problem. And actually, patients require surgery very, very infrequently. It's a very rare thing to need surgery from this issue. So the oral medicines that we use instead of warfarin for the giant aneurysm patients, we use something called apixaban, Apixaban, apixaban. And that is the brand name for the medicine, no, that's the generic name, apixaban. Eliquis is the brand name. There's like 3 or 4 different DOACs and they all have, I always have to look them up. Eliquis is the brand name. Apixaban is the generic name. There are 3 others that are approved, but we tend to use apixaban the most because we were part of the trial that looked at the pediatric dosing, and we had, I think, 3 patients with Kawasaki disease enroll in the pharmaceutical trial looking at safety profile. So we are familiar with apixaban, and we like apixaban. That's what we use. It's easy to dose. You use it and you take it twice a day. What size Z-score would be considered an aneurysm? Good question. I almost had that slide in there, but I think I ran out of time. So a small aneurysm is Z-scores of plus 2.5 to plus 5. A medium aneurysm is plus 5 to plus 10. And then a large or giant aneurysm is greater than plus 10. And we do have patients with Z-scores of plus 20 and things like that in infancy. So it can go as high as it needs to go, small, medium, and large.
So we're going to break now, and I'll reconvene back here at 10:45. So those of you here in the audience, we look forward to seeing you for a cup of coffee outside, and then we'll all regather here, and we'll have another dynamic program in the last half of the morning. So thank you. I'm happy to kick off the second morning session of our Kawasaki Disease Parent Symposium. And our first speaker for this session is going to be Dr. Lori Daniels, who is an adult cardiologist, head of the critical care unit for people with heart disease at the University of California, San Diego, at our Sulpizio Cardiovascular Center. And Lori's been involved in studies of adult Kawasaki disease for over a decade, and has a wealth of information and is part of a team of adult cardiologists who are specializing and studying the long-term outcomes. So for those of you who had questions from the first session, we're going to get to those at the end of this session when we have Dr. Daniels here to help answer those questions. So, Dr. Daniels.
Thanks, Dr. Burns. So today, as Dr. Burns said, I'm going to be speaking a little bit about what we know of the long-term consequences of having Kawasaki disease. We'll touch briefly on the safety of pregnancy after Kawasaki disease, which for some patients might seem like eons away and for others maybe more imminent. And then a couple of tips on how to stay healthy after KD. I want to kind of start with the take-home point that I hope you leave this talk with, because a lot of folks are often anxious about what they need to know about the future. And I think from everything we've learned and others have learned, if you had an echocardiogram at a reliable institution and it was always normal, we've not found any long-term concerns or abnormalities with health. And we don't believe you need Kawasaki disease-specific long-term follow-up into adulthood. On the other hand, if there were abnormalities such as aneurysms or dilated arteries, or if you don't know because you never had an echocardiogram of reliable quality, then yes, we think that follow-up is a smart thing to do just to be safe. So to study this systematically, we established the San Diego Adult KD Collaborative. And I'm not sure how many years old it is now. It's at least a decade, probably 15 years because time flies. But we've been looking at this for a while. And the overall goal of the study is to help us learn what the future holds for individuals who have a history of Kawasaki disease. How will having had Kawasaki disease affect your future cardiovascular health? And as I mentioned, if you had a normal echo, what's your risk? Do you still have risk, or are you in the clear? So to study this, we've enrolled 3 groups of individuals. Cohort 1 is the group of young adults, 15 and up, who have a history of Kawasaki disease, and they were diagnosed and followed here at Rady Children's Hospital in San Diego since childhood. Those are the folks that we know their entire entire time course of their disease. Since they were treated here, we have all the records. Cohort 2 is also an important group. It's individuals with a history of Kawasaki disease, but who were diagnosed and treated somewhere else. And then they found our study, or we found them, and they wanted to enroll and help the numbers. We don't necessarily have as much information about their early Kawasaki days, although we have often have records, but we can certainly follow them for outcomes. And an important group, and we've talked a little bit about controls in some of the earlier talks today, is that we have a group of controls, healthy volunteers. Some can be healthy best friends of Kawasaki disease patients, but really any volunteer of similar age to the young adults in the study, so that we have a comparison to make. And this is just kind of a little picture to show the importance of having a control group. So if we have a group of interest, in this case, people who've had a history of Kawasaki disease, and then maybe we'll take their healthy friends who are similar age or volunteers, we follow them over time. If we say, okay, 3 people end up getting, any outcome of interest, say chest pain. Well, some of the healthy volunteers are going to get chest pain as well, and this allows us to compared to a background, what's normal in the general population. The main focus of the study at this point is questionnaires. We do a baseline questionnaire where we get a full medical history and we ask a lot about symptoms. And then we are going to be doing, and we have been doing in some cases, follow-up questionnaires every 2 to 3 years, shorter, but just to check in, how are things going, any new diagnoses, any new symptoms. Our current enrollment in Cohort 1, we have 189 individual young adults with a history of Kawasaki disease, and in Cohort 2, again, those are people who found us, but also with Kawasaki disease, 147. So we're doing pretty well. And what have we learned so far? We had a publication just earlier this year about the long-term health outcomes after Kawasaki disease. So this is published now. And we did a focus on symptoms. What are the symptoms in Kawasaki disease patients? Now, what this particular graph shows is the patients, not patients anymore, but the young adults with a history of Kawasaki disease, I'll use the term patients just because it's easier to say, who had normal coronary arteries, not individuals with aneurysms or transient dilation. So those are in blue compared to the control healthy volunteers in orange. And there were some symptoms that even these individuals with normal coronary arteries reported more often. Now the numbers here are relatively small. At this point there were 128. This is cohort 1 and cohort 2 together compared to 148 controls. But you can see that, palpitations, chest pain, migraine headaches, and even attention deficit disorder, or ADD, were reported a little bit more commonly in young adults with a history of KD. Now, I want to be careful to point out that does not mean that Kawasaki is causing these things, and there's a lot of potential reasons for this. In one part, you can think that individuals with a history of Kawasaki disease have more access to doctors and have had more doctor visits, right? So there could be some degree of anxiety or some bias because they're seeing doctors who are asking all these questions all the time. So we really have to be careful about implying causality. And I want to emphasize, despite these symptoms, there's no increased diagnosis of heart conditions that are dangerous, like heart attacks or things like that. But the one that stood out for us is they're more frequently at least having the experience of chest pain, even without a diagnosis of heart attack or things like that, and also migraine headaches. And the reason those two stood out with us together is that it's possible that after Kawasaki disease, there's some abnormal reactivity of the blood vessels. Both migraine headaches are actually caused by blood vessels widening, and you get excess blood flow in your brain. And some types of chest pain can be due to abnormal tightening and widening of blood vessels as well. So one hypothesis is that maybe there's some sort of abnormal blood vessel reactivity here, or maybe there's some genetic susceptibility to blood vessel abnormalities. We don't know that. These numbers are small, but it's a possibility. On the other hand, as I said, it could just be there's a heightened awareness of symptoms, because if you know you've had Kawasaki disease, you might be thinking about it more. ADHD is another thing that's of interest. We found that it was more common both in cohort 1 and cohort 2, young adults compared to controls. Other countries have looked at this, Taiwan and Japan, and have mixed results. Some found increased ADHD after Kawasaki disease. Others found that it was the same. So, again, these numbers are still really small, and so we need to see if this is real or just an accidental finding, since when you look at 200 different symptoms, by chance, some of them are going to look different when you have small numbers. What about Kawasaki disease individuals who had coronary aneurysms? Still, overall, I would say they're also doing well, but they have some symptoms more than the controls. As you can see here, palpitations, chest pain. They did not have significantly more migraines. In science, we consider a p-value of 0.05 to be a significant difference, and anything over that we consider to be there's a reasonable chance that it was due to chance. So, migraines, ADHD, not more common, but maybe a little bit more depression. But overall, the numbers are quite small, even, under 20% there. And when you ask how your health is, most of these individuals are still saying that their overall health is excellent or very good. Even the young adults with a history of coronary aneurysms, 62% rate their health as excellent or very good. So despite these symptoms, despite having aneurysms, and only 13% of those with aneurysms report fair or poor, and the rest reported, good, somewhere, or average. We also talked a little bit earlier today about coronary calcification that you can see on CT scans. This is an important part of our recommendations for how to evaluate people after Kawasaki disease, especially if you don't really know your history very well. And this is an example. There was a 35-year-old uncle of one of Dr. Burns' patients who had Kawasaki disease. And the uncle himself had a history of KD when he was 1 year old. He was told his coronaries were normal and no follow-up was needed, but there was not a lot of confidence in the site where he had his evaluation at age 1. He enrolled in our adult KD study, got a CT calcium score, and it was markedly elevated. And this is just one example of a picture. You can see the arrows pointing to some calcification at the takeoff of his coronary artery. So we ended up doing another type of CT study called a CT angiogram, where we inject contrast to actually visualize the arteries. And sure enough, he had a 7-millimeter coronary artery aneurysm. So he was started on warfarin. This was before the apixaban study, and aspirin at that time. But the CT calcium score helped us be alerted to this possibility. So our group has studied CT calcium scoring as well after Kawasaki disease. And what in this picture, in the black dots are the Kawasaki disease patients, or history of Kawasaki disease, who always had normal coronary arteries. And in blue are the ones with a history of aneurysms. And what you can see is that the x-axis is the number of years since their diagnosis of KD. So what you can see is that individuals who always had normal coronary arteries, those are the black dots, have no calcium. All of them are on that bottom line. But almost everyone, with basically only one exception out here, almost everyone with aneurysms has calcification once you're 10 years out from your diagnosis. So if your KD was more than 10 years ago and you had coronary artery problems, aneurysms, you're going to have calcification. And that's why the calcium score is such an important part of our screening. If you're more than 10 years out and you get a calcium score and you have no calcium, that's a really good sign. If you have calcium, then we do further workup. So no calcium in those with prior KD who had normal coronaries during their acute illness. A few words about the safety of pregnancy after Kawasaki disease. We recommend those with a history of Kawasaki disease and abnormal coronary arteries to have a cardiologist on board, as well as maternal fetal medicine, so not just a standard OB-GYN. And the reason for that is you'll have people who are knowledgeable in how to deal with this. But Dr. Burns' daughter actually led this study, and she's a physician now out in Boston still. And she studied 21 pregnancies among 10 women, so some women had more than one pregnancy. And 4 of these women had a history of coronary artery aneurysms. 2 of the 21 progeny ended up developing Kawasaki disease over the years, so a genetic component, of course. But they did well. And so we do not recommend termination of pregnancy. In most women with KD, it's safe to have kids, but we do recommend management by a team of specialists. Normal labor and delivery is possible with some adjustment of medications. And, there's probably some counseling warranted for genetic risk of KD in the offspring. Finally, what else can I do to stay healthy after KD? It's extremely important, if you've had a history of KD, to not smoke. Smoking and methamphetamine and cocaine use is dangerous in anyone, but it's especially dangerous in people with a history of KD, and especially so if you have aneurysms. We've seen some really horrendous outcomes in people who get mixed up in this stuff. The hearts just do not tolerate it after KD. Heart-healthy diet is important for everyone, but especially after KD, so lots of fruits and vegetables, whole grains, maybe a handful of nuts a day. Try to avoid fried foods and saturated fats. Olive oil is better. Just heart-healthy, smart things. That doesn't mean you can never have French fries, but I always tell them, when you do, enjoy them, don't scarf them, make it a special, appreciated thing, right? And try to be heart-healthy. Exercise, regular aerobic exercise. Yes, it's okay to run. It's okay, maybe not a marathon because you don't want to get dehydrated, but we want you to stay healthy so you can be physically fit. And if you have normal coronaries, you can certainly do a marathon if you train adequately and hydrate adequately. It's okay to get your heart rate up. That keeps you healthy. And then Dr. Tremoulet already talked about statin medications, and she already kind of did a good job, so I'm not going to go into too much details about this. But it's not the same reason we give it in adults. It's not to lower cholesterol. It's to help the actual health of the blood vessels, and we think that's a good thing. So with good care and paying attention to these heart-healthy habits, we do think the future is bright for anyone with a history of Kawasaki disease. Again, if your echo is always normal, you're okay. But if you had aneurysms, we do recommend a follow-up with an adult cardiologist, preferably one who's knowledgeable about KD. If you had transient dilation and the arteries returned to normal, we're not sure yet. We're studying that. It's probably best to get follow-up just to be safe. And if you don't know your coronary artery status, then we recommend getting a CT calcium score when it's been at least 10 years since your KD, and then follow up with a cardiologist who's knowledgeable about it. So, final slide. We hope you're interested in joining the adult KD study if you haven't already. We're still enrolling. You can sign up, fill out the questionnaire. If you're a KD patient, we especially want you involved. If you're 15, healthy controls, we need you as well. And if you know someone who has a history of KD, encourage them to sign up too. So you can email us at adultkd@ucsd.edu. Thank you very much. Thanks to the KD patients and families, as well as our healthy controls. The Dawn and Patty Dawn and the Macklin Foundation, who helped fund a lot of this research. We couldn't have done it without them, as did the American Heart Association, and to all my colleagues who have been studying this. Thank you.
So the final two talks today are going to be mine, and thank you, Dr. Daniels, for that. We're going to switch gears a little bit and talk about the genetics, and there were some preview of that in Dr. Daniels' talk, where she talked about the parents who had Kawasaki disease and then gave birth to children who then went on to also get Kawasaki disease. And that's a thing, and it's a thing because there is a very important genetic component to Kawasaki disease. So this is from a recent review paper that I participated in writing about the epidemiology, the study of populations who have Kawasaki disease. And what you see here is the color scale. This is incidence per 100,000 children less than 5 years of age, and if it's a very dark color, it's a lot, and if it's a mustard color, it's less. And these are the countries of the world where we had data. And here's Japan, so country of highest incidence. Korea is next, and Taiwan, and then China. We don't have good denominator data, so the Chinese haven't been good about knowing population numbers, but certainly they have a lot of Kawasaki disease. And then you kind of have the rest of the world here with a lower incidence. So why is this? Is it just because this region of the world gets exposed to the triggers of Kawasaki disease? We don't think so. We think that there's a powerful genetic component. And we see that here in our own population in San Diego. So if you're my next door neighbor in La Jolla and you are of Asian descent, your child has a 4 times increased relative risk of being born with a genetic pattern that will make them susceptible to breathing in the whatevers that trigger this disease. So here you can see in the green bars across here, this is the KD cases per 100,000 children less than 5 in our Asian population. And of course, this was the pandemic situation here where you saw all our numbers go down. But you can see that in any given year, our Asian children are at highest risk of getting Kawasaki disease, followed by African Americans and then Hispanics, and Caucasians in the red bar probably being less susceptible. So the evidence that there's a genetic influence on who is susceptible to Kawasaki disease comes from this increase in the Asian populations. We know from excellent work done in Japan that siblings of a KD patient have a 10-fold increased relative risk, and that there's a 2-fold likelihood increased likelihood of a history of KD in a parent of a child who is now being diagnosed with Kawasaki disease. And again, this is from Japan where the numbers are much larger. We do have many parent-child pairs that we follow in our clinic, but we have much smaller numbers than the group in Japan, but we've certainly seen it. And these are families that we follow here in San Diego. We call these Kawasaki disease pedigrees. So the circles are the females and the squares are the males. And here you see a family where there was an uncle of these children who had Kawasaki disease, or it could be a parent and a child or siblings. So we know that it runs in families. Here's a bigger diagram of some of the families that we follow. And you can see that there are families of all different racial and ethnic backgrounds where there have been multiple affected members. And we are getting ready to study this in great detail. So the way we study genetics is to actually look at the molecules that make up the information in all of our cells, the DNA. And that process of studying that chain of molecules that make up the DNA chain has really, really evolved over time. So we published the second paper in the world to be published on the genetics of Kawasaki disease, and this was Dr. Shimizu, who's here today, and other colleagues in our laboratory actually doing this by hand. So molecular methods that were pretty primitive at the time, and doing this by hand. And we were just looking at 2 little places. So it's 1 billion molecules long, and we were just looking at 2 little places in the DNA. That's what people knew how to do in 2001. In 2017, we published the first whole genome sequencing. In this case, it was an African American family where there were 2 affected children, 2 unaffected siblings, and the parents had never had KD. And this led us to identify a change in the DNA and the genetic code that was probably private to this family, because when we went back and tried to look for this same variation in our other DNA samples, which we thank you all for contributing to this study, we didn't find that it was a generalized change, but it was something that was private to this family. And it was a change in the DNA sequence that affected a molecule that then got us thinking that that particular protein was important somehow in increasing susceptibility to Kawasaki disease. Well, we are about to get a flood of genetic data because the technology now has gone light years ahead, and we're thrilled about that. We're a little bit nervous about how we're going to deal with all these data. But there's certainly been an important evolution in what we can learn and how we study the DNA in human populations. And it requires a whole new type of person to actually do the analysis of this giant, giant volume of information. So these people are called bioinformaticians, and I like to think of them as the superheroes of modern biomedical research. And why are they a special breed of person? They have training that I never had when I was in medical school, and it's an important combination of having knowledge about biology, a very in-depth knowledge of statistics, and a way to analyze data using all kinds of computer methods. They need to be able to program to actually have the computer help them do the work. And they are data scientists. So this is our new group of people who have joined the workforce in the analysis of these data. And we're really lucky to have three wonderful people that we collaborate with, Ji-Hoon Kim, Hao Wang, and in the Imperial College group in London, Mersini Kafaru. So all of these people work in groups and have the abilities and the training and the knowledge base that you see pictured here that's really required to analyze these data. So when we talk about genetic variants, we're not talking about something wrong with you. We're not talking about mutations. We're talking just about differences. So when we look at populations of people, there's a letter code to the DNA sequence. Each one of these is a molecule, and there can be variants, and that's where these big V's are. And this doesn't mean that this person has a mutation or there's something wrong. These can be common across a population, but it could be in a given gene that you have a series of variants along that gene, and it's that combination of variants that creates susceptibility, not just in one gene, but actually in several different genes that may all be in one particular inflammation pathway or a metabolic pathway. So it's a very complicated analysis. It is not easy. It's not going to be easy, but we're up to the challenge. One of the ways that we do this kind of analysis is by getting DNA from the parents. And for those of you who have been to our clinic, you get to rinse your mouth. If you're a parent, you get to rinse your mouth with Scope mouthwash. You leave our clinic with a really, really clean mouth. That's one of the advantages of coming to our clinic. And you probably weren't expecting that when you came to the clinic, but we're very grateful to you for donating the cells from your mouth from which we can then isolate your DNA. And why do we want to look at the parents? The parents never had Kawasaki disease, so why are we studying them? We're studying them because at many different places along the sequence of molecules in the DNA, the parents have a choice of the two chromosomes, which one is going to be passed down to their offspring, right? Every time you make a new human being, you roll those genetic dice and you get a different combination. So in this particular example, a parent has a choice of whether they send down this chromosome or this chromosome, and you can think of it as the inheritance of either A or the inheritance of B. And when we do the analysis, when we genotype the parent and we genotype their biologic offspring, if the transmission of A and B is equal, so if we look at a large population, half of the time a parent sent down A and half of the time the parent sent down B, then we know that A and B have no effect on KD susceptibility because we know the child has the genetic pattern. If, however, there's a disequilibrium in the transmission or a difference in the rate at which B is transmitted in this example, then we know that if we look across 100 people, if we look across 1,000 people, and more of the time that B allele, so that marker, goes down to the child who's affected, then we know that B had a positive effect on KD susceptibility. So that's why we're doing the mouthwash in our clinic. We're really, really excited about a bright future coming our way for the genetics of Kawasaki disease. And this was made possible by a very generous donation from the Gordon and Marilyn Macklin Foundation and the Dawn family. And what they did, which is just an incredible move on their part, was to make a very large gift. It wasn't large enough to get us where we needed to go, but it was large enough to get the interest of Illumina, which is a local genotyping company. They make the NovaSeq, which is the major genotyping machine right now that reads the genetic code and spits out that information. And their donation got the interest and the attention of Illumina, who was then able, or willing, I should say, to jump in and match that funding, so that now we are in the process of doing whole genome sequencing on this large group of our patients here that includes over 250 Hispanic trios, meaning the KD child and their biologic parents, 17 of our complex pedigrees, so those pictures I showed you where there are multiple affected members. We're also going to be looking at our MIS-C patients. So these are the kids who had that very strange reaction to being infected with the SARS-CoV-2 virus. And hopefully out of all of this information is going to come the understanding of why your child was susceptible to Kawasaki disease. And perhaps we're also going to get some clues about what the agent or agents of Kawasaki disease are that trigger this. Incredibly, Illumina has also jumped in and said that they're going to look at the RNA in the blood of these patients. And the RNA is a way to interrogate what the cells that were circulating in the blood were thinking. It's a way to look at the brain of those cells and what they were thinking when your child was sick. So this treasure trove of information is unique, certainly in my lifetime, and an amazing, amazing step forward. We're hoping to have all of the sequencing done by the end of this year. So I can't say enough of a thank you to all of the families who have donated their DNA for these studies. We could not have done it without you. We're still very interested in collecting DNA from families with aneurysms. As Dr. Doomer said, we don't have a lot of aneurysm families here in San Diego maybe because of our aggressive treatment initially of our patients, thanks to the work that Dr. Tremoulet has done. So if you're somewhere else in the world and you'd like to participate, we can send you kits and the consent forms to participate in our genetic studies. So thank you to everybody. So that's the genetic segment. I think I'm up for the next talk, which is really more about you than it is about us. And after this, we're going to have our questions. So please, in the chat, or if you're online, please get your questions into us so that we can answer them in the next Q&A session. So I wanted to finish up this morning with what I'll call a call to action. We think we do a really good job here in San Diego, having educated our incredible general pediatric community, having partnered with our emergency room. There are not a lot of missed Kawasaki disease patients here in San Diego. But in other parts of the country, in other parts of the state, we just learned about the death of a baby in Northern California. This diagnosis continues to be missed, and you can play a really powerful role in making that stop. So first of all, as I said, the Macklin Foundation has really breathed new life into our adult KD cooperative. Angie Rodriguez-Verdin is our new research coordinator funded by this grant. And if your child is at least 15 years old and you live somewhere else and you'd like to sign up for our adult KD study, please do that. There's a QR code that was outside. I think it's going to be posted online. And you can simply email us at adultkd@ucsd.edu. So that's how you can be part of answering the questions that remain about the mystery of Kawasaki disease. You can also harness the power of social media to spread the word about KD. We've certainly seen during the pandemic how social media can be used for bad purposes, but we'd like you to use your social media presence to send out information to everybody you know about Kawasaki disease. It's a visual diagnosis, right? It looks like this, okay? This is a poster that's available from the KD Foundation, and you know that you don't have to have gone to medical school to make the diagnosis of KD. So let people know in your universe that this disease exists, that your child was affected, that you never want another child to have a misdiagnosis in this country, or anywhere else in the world for that matter. Here are reliable sources of information about Kawasaki disease. A huge shout out to the KD Foundation that sponsored the live streaming, that sponsors this symposium every year, year in, year out. I think we're in our 14th year. And we're grateful to their support, but they're a wonderful, wonderful source of information that's reliable, that's accurate. And they also have support for parents who may be having a difficult time getting through Kawasaki disease and the illness of their child. So please reach out to them. And then the UCSD KD Research Center, we have lots of information posted there about the ongoing work that is supported by you, our families. So the KD Foundation has a big presence on social media. I have to tell you, I'm not on social media because I can't even keep up with my email, but I'm glad that other people are, and so please do that for me because I'm not there, but you can be there. And these are all the social media outlets that are maintained by the KD Foundation. So again, this poster is available. Now let me make a suggestion. If you took your child in to an emergency room or an urgent care or a somewhere, and they said to you, this is just a virus, go home, or this is nothing, don't worry about it, please either ask us if you're one of our patients that we follow in our clinic, or reach out to the KD Foundation who has posters available of these pictures and some text associated with it. Ask them to send you that poster, go to the place that missed the diagnosis in your child, and ask them in a friendly, nice way, would they be willing to put it up on the wall in their clinic, in their emergency room, in the waiting room of their office, where other parents can see it. Because parents are the way that we get the diagnosis made in this disease. It's teamwork, right? And if a parent goes in, having seen these pictures, and says to the doctor in whatever urgent care, I've seen the pictures online, or I've seen the pictures here in this poster, I'm worried that my child might have Kawasaki disease. That's all that needs to happen. That triggers a whole set of events that will make sure that the proper evaluation and consideration of the diagnosis happens. So it's not that doctors aren't trained to recognize it, it just may not pop up on their internal brain computer screen when they're seeing your child. And particularly now in this particular moment when we're overwhelmed with respiratory viruses, and many of these respiratory viruses cause either bloodshot eyes or rash or some combination, they may not be thinking about Kawasaki disease. So we really want you to take the responsibility on yourself to help get this word out. If during the process of trying to make the diagnosis of Kawasaki disease in your child, a lymph node biopsy was done. Sometimes these children come in with really large lymph nodes, and the thought is that it's a bacterial infection in the lymph node. And sometimes biopsies are done. It's a fine needle biopsy. It's not very invasive. The children tolerate it well under gentle anesthesia. But if that were done and that tissue exists somewhere because it's put into a little block of paraffin and exists, or an appendix was taken out because of abdominal pain, or a gallbladder was taken out, anything that was removed from your child could actually provide huge clues to the nature of Kawasaki disease and our team here at the KD Research Center is equipped to really take maximal advantage of that. So let us know. Email us at kdresearch@ucsd.edu if there's a tissue block somewhere in the world that you would like to donate for our research. We have consent forms that you can sign and turn that over to us. And finally, we've had so many questions about the COVID vaccine. And we want to urge and reassure you that the COVID vaccine, the SARS-CoV-2 vaccine, either the RNA version or any other version if you live in another country, as far as we have been able to study and for all the reasons that we've considered, is absolutely safe for children who have had Kawasaki disease. Whether you have aneurysms, you don't have aneurysms, please get your children protected. And we actually did a little study. One of our summer students did a study in our clinic where we interviewed people. We were sad that in our clinic only half of the children coming for follow-up had been vaccinated. But of the 51 children who had Kawasaki disease with or without aneurysms and had received a second dose of the COVID-19 vaccine, fully half of them had 0 symptoms at all from the vaccine. 24 of them did experience some symptoms, and it was basically a sore arm. Okay, so you can see these numbers here are very small. Across here, they add up to more than 24 just because some children had fatigue and a sore arm. But these are really minor things when you compare it to what it can be like to have the COVID infection. So please get yourself vaccinated, get your children vaccinated. There's so much disinformation about this vaccine out there. It makes our job really hard. And finally, I want to thank Amy Weeks and the Rady Children's Hospital Foundation, who have been the interface for all donors who are interested in supporting our work. The way that biomedical research is usually funded is through institutions like the NIH, your tax dollar at work that gets funneled into biomedical research. But when you have an uncommon, I'm not going to call it a rare disease because I really think it's just, let's use the uncommon word. But when you have a small segment of children who are affected by this and you're competing with asthma and diabetes and much larger problems, and I don't mean to take away from the importance of those problems, but it's just there's a lot of competition for a very small pie. And the role of philanthropy in supporting our research is the only reason that we are here today. Without philanthropy, we would have folded and we would not have been able to carry out the mission of research and improving the care for children with Kawasaki disease. So any amount is welcome. There is no overhead that's taken. We're not a big organization with lots of employees, et cetera. No. We're just the people that you saw here today. And we're on the front lines, we're taking care of your children, and we're joined by a talented group of people in the laboratory doing research. So no overhead, all your money goes to the effort, and we really appreciate it. And Amy is, I believe, here today, but always available at aweeks@rchsd.org. So with that, we're going to conclude and answer your questions. So please pass them in if you have them, and we're going to get questions from the folks online. And Lori, if you would come up, there are questions from the previous session that we saved for you. So come on up.
Okay, some of them are for you. Okay, so some of these questions I may have answered in my talk already, but we'll read through them. What should the follow-up be for an adult who had KD when 5 years old? When 5 years old, needed 2 rounds of IVIG, 1 round of prednisone, developed 1 aneurysm, which resolved a month later. So, that resolved aneurysms means that the echo was not always normal. Most likely, this individual will be fine, but we do recommend follow-up long-term with an adult cardiologist who can check, who's knowledgeable in Kawasaki disease preferably, who can follow up with you for development of, of symptoms and things like that. If symptoms were to develop, they could order the appropriate tests. And obviously, heart-healthy diet, avoiding smoking, and all of the things that I previously discussed. What are the current recommendations for long-term follow-up of adults who had KD with aneurysm that regressed during early childhood? I think that's a very similar question, same answer. My son was diagnosed with atypical Kawasaki disease in 2004 and is now 20 years old. I'm not sure of the math on that, but okay. What must be done? So I think the question for your son is, number one, what was his disease course? How were his coronary arteries at the time? If you were at a reliable institution that's used to dealing with Kawasaki disease and the coronary arteries were always normal, I think you're fine. Just, live a nice, healthy life. If there were coronary artery abnormalities, your son should get follow-up. If you're not sure, or if there was no good study done, now that he's more than 10 years out. Oh, I see. He was diagnosed in 2004. So there's the math. My brain's a little fuzzy today. He was diagnosed in 2004, and now he's 20. So he was a few years old when he had it. But so that means it's been 16 years since the Kawasaki disease. That's more than 10 years. So if you don't know how his coronary arteries were at the time of diagnosis, then we would recommend a CT calcium scan. If there's no calcium there, I think you're in good shape. If there is some calcium there, then we would recommend, again, follow-up with a cardiologist who's knowledgeable about Kawasaki disease. They might recommend a CT coronary angiogram to look at the coronary arteries. Have we studied adults with a history of KD and the prevalence of coronary artery disease as adults? So coronary artery disease, as opposed to aneurysms from KD, are a completely separate problem. And it's a completely different pathology, and it's not related to Kawasaki disease at all. Coronary artery disease is the more typical atherosclerosis, or the plaque that builds up in our arteries over a lifetime of either bad genetics or unhealthy habits. And we don't believe that Kawasaki disease influences the prevalence of coronary artery disease. However, individuals with a history of Kawasaki disease and coronary artery abnormalities can get blockages in their heart arteries. It's a different histology. It's a different cell makeup than typical heart disease that causes the more typical heart attacks. But we don't think that the more typical kinds of heart attacks are any different or any higher in individuals with prior Kawasaki disease. My son, who is now 32, just had brachytherapy and 5 cardiac procedures. He had KD at 16, but was not treated at that time. He had myocardial infarction at 17, right coronary artery with stents. Is there a research center in the upper northeast coast? This is a really unfortunate scenario that is unfortunately somewhat common in people who have Kawasaki disease that gets undiagnosed. It can be hard to diagnose, I think, when you're older. 16 teenagers, a lot of doctors don't think of Kawasaki disease at that age. So I'm sorry to hear your son is going through all that. It's obviously a very stressful thing to go through, but we are seeing that when young adults have heart attacks, and when I say young adults, anyone under the age of 30 who has a heart attack, we think that Kawasaki disease is a very common culprit, missed Kawasaki disease, and we've published on this, in fact. And individuals who 20-year-olds and teenagers shouldn't be presenting with heart attacks, and when they do, sometimes we find that they have big aneurysms because they had Kawasaki disease as a child that was never diagnosed and treated, unfortunately. So the scenario you're describing, we're hoping to prevent in the future with better education. But to answer your actual question, is there a research center in the upper northeast coast? I think that I would probably refer you to Jane Newberger Center at Boston Children's Hospital. That would be my recommendation. And finally, I think this is actually for Dr. Burns, but Japanese children are more vulnerable for KD, and it's interesting that respiratory virus is relevant. Japanese also have the highest prevalence of respiratory panbronchiolitis. Are you aware that there are ethnic relevant immunological reasons that these could be linked?
So we hope that the huge genotyping effort that's underway is maybe going to address something about this question. It's basically asking if a population has a problem with this disease and they have a problem with that disease, is there a reason that those are linked? And causality is really complicated, but clearly our children who have had Kawasaki disease appear to go on and be immunologically normal after that. So they're not more susceptible to infections. They're not more this, more that. The only thing that I would mention, and this was one of the other questions, is eczema. So eczema is also an baseline genetic condition where you're predisposed to it, and you'll usually see eczema run in families. It's a skin condition with dry, itchy skin that children can outgrow. And it does seem in the big databases in Japan and Taiwan and Korea where this has been looked at that Kawasaki disease and eczema may be linked. And perhaps we'll get some more information about that from our giant genotyping study that's underway. But it's very hard to make links between things except to say that in one population, a second condition is more common, but it may be common for completely different reasons. So 2 different pathways and not related. Anyway, complicated answer to a complicated question.
This question asks, are the adults in the study still on medications? I think you're referring to the adult KD collaborative. So I want to be clear, this is an observational study, not a interventional study. And by that, I mean, we don't do anything to you. We don't give you medicines. We're just asking you questions and observing what happens. So if you are on medicines, you stay on them. That's between you and your doctors. The adult KD collaborative, we're just here to kind of report on what you tell us. So yes, some of the individuals are on medicines, others are not. And also, thanks to this question, I do want to address one other point. We talked earlier before the break about the long-term effects of warfarin or Coumadin or rat poison. And Dr. Doomer mentioned that she sees a lot of children who get calcium buildup from it. I want to emphasize, as an adult cardiologist, I have many, many patients on warfarin for many, many years, and most of them do not get that. That is a known potential side effect, but back in the days, 10 years ago, warfarin was all we had, and many patients were on it safely, and it saves their lives for many years. And anyone with a mechanical heart valve, not related to KD, now I'm just talking patients in general, they have to take warfarin, and it saves their life, and they are on it for decades, and most of them do just fine. So calcification can happen, but at least in adults, I can't speak for kids, at least in young adults and in adults, it's relatively safe. And if your doctor prescribes it and you're not a candidate for one of the newer DOACs or one of the newer meds, it's definitely safer to take it and prevent blood clots than to not take it.
And maybe just to further clarify that, Kawasaki disease and warfarin leads to calcification. And it has to do with inflammation. It has to do with layering down very gently of blood clots in those big aneurysms. And so Kawasaki disease and warfarin is one thing. Warfarin and all the other conditions that Dr. Daniels was talking about is another situation and may not at all be related to calcification in those other diseases. But there are alternatives that are safe for Kawasaki disease patients. And we would really urge you, if your child is on warfarin, to ask your cardiologist about the potential to switch to one of these newer agents that are oral, they don't require monitoring, and they appear to be very safe and effective. They also have reversal agents available, although expensive, but available. So I'll take a couple of questions, and then we have Dr. Doomer and Dr. Tremoulet are going to take some more questions. One was, should we have a sibling checked for Kawasaki disease? Well, we don't have any genetic test right now where we can check anybody for their predisposition to Kawasaki disease. We hope that we're going to have that. We hope that this might, many years down the road with all the analysis that we're doing from this huge data set, we hope that we'll have such a test, but it doesn't exist right now. And the sibling situation is that siblings born to the same biologic parents share 50% of their genes are identical and 50% are completely different. And you already know that because your children are very different from each other, right? And that's because they only share half of their genetic material. And so the chance, while it can happen, but it's still quite uncommon that you roll those dice and two children in the same family inherit exactly the same complicated pattern that leads to susceptibility to Kawasaki disease. It can happen, but not very often. There's a question, what is the treatment for calcium buildup? And there is no treatment for that. So once that artery is calcified, we don't have a way to undo that. And a question about follow-up for a patient who sounds like might have been in one of our clinical trials, but isn't being seen at Rady's anymore. If we discharge you from care and you had your exit visit and we didn't think you needed follow-up anymore, then that's still true.
So there are a couple of questions about inflammation in different body systems outside of the heart. One has to do with if you've had KD, are you at any increased chance or severity of subsequent respiratory infections? And as far as we know, the answer is no. You're not susceptible to anything further in terms of respiratory infections. Although as an infectious disease person, I'll tell you, go get your flu shot now. The other thing is about the urinary tract. Some of you are well aware that one of the ways that one of the tests that helps us in the diagnosis of children with Kawasaki disease is from collecting urine and looking at white blood cells. There's something called sterile pyuria. And so there's a family that's asking about their child getting sterile pyuria when they're ill with other illnesses. This is something we find in children with KD, like there's inflammation in different body parts, but there's nothing chronic about this. This doesn't cause an increased risk for urinary tract infections. It's actually not even presents, it doesn't have any symptoms in our children with KD. So if you are having a child that's been found to have pyuria outside of having Kawasaki disease, then that needs further workup by your pediatrician, looking for other things like infections of the urinary tract that may cause pyuria. There was a question about pictures. Is there research being done to combine images that we were showing from the poster with lab tests, looking at risks for Kawasaki disease? And in fact, we're in the midst of doing that right now with Jonathan and our artificial intelligence group. Some of you may remember from last year that Ellen Zhu presented her work with us. She's very much involved with the KD Foundation Youth Group, and a big shout out to her for all the work that she's done. We published a paper in the last year that showed that if you're looking at photos of the eyes or photos of the rash or photos of the lips, that pictures, a computer through an algorithm can actually predict with pretty high rate that that is a photo that looks like Kawasaki disease or it does not. So right now what we're doing is working further on validating those findings, also working with Jonathan and his group in combination with the algorithm that he showed. So can we mix photos with lab data together? Does that help us pick out kids that need further evaluation with KD more or less than just the algorithm itself? And we're working on that actively, so more to come with the next symposium on additional decision support tools that help our physicians in the community, in our urgent cares, and in our EDs to help better diagnose children with KD.
There's a really interesting question here about whether a coronavirus strain could trigger KD. So to go inside the brain of the person who asked this question, I think what they're getting at is MIS-C was a hyperinflammatory condition that followed 4 to 6 weeks after the child was initially exposed to the coronavirus, to SARS-CoV-2. And they didn't have a lot of infection problems necessarily when they were first exposed to the virus, and they did fine. And then all of a sudden, 4 to 6 weeks later, they erupted with this huge inflammatory response and inflammation in the heart and all kinds of problems. So we also had the same thought. Could there be a coronavirus that we haven't discovered yet that could be an infection that didn't get a lot of attention initially, and then 4 to 6 weeks later, boom, you erupt with Kawasaki disease? So it's a great question. We had the same question. And we partnered with a group at Columbia University in New York that have a method of looking across all coronaviruses. So the one that infects camels and bats and civets and all these different animals and all the human coronaviruses. And if you can imagine, they sort of lay out all the proteins from these viruses on a big, imagine it like a table. And then we could put a drop of Kawasaki disease serum on it and see if there are any antibodies that are recognizing these viruses with a higher than would be predicted rate. And we were so excited because we thought maybe this was going to be an answer for Kawasaki disease, and we came up empty-handed. So there does not seem to be a novel coronavirus that triggers Kawasaki disease. We're still mining those data a little bit and revisiting it. It also doesn't seem to be exposure to one of the known cold coronaviruses. So, before we had SARS-CoV-2, there were 4 coronaviruses that we knew about that cause common colds, basically. And we have a test that we do at Rady Children's Hospital from a nose swab that most hospitals across the United States can also do, that tell you whether or not you have that coronavirus, just the cold coronavirus. There also didn't seem to be an association with that. So juries may be still out a little bit, but I think the answer is probably not. But it was a great question. And then there's a question about any data about the offspring of males having KD. So I think this is asking, not quite sure, this could be asking if the father had Kawasaki disease in childhood, is it more likely that that person's child would then have Kawasaki disease versus if the mother had it? Maybe that's what this question means. And the answer is we haven't seen that. So in the Japanese data set where they have a larger number of patients, it seems to be equally probable if the father passes it down, the pattern, genetic pattern, versus the mother passes it down. So we haven't seen that. And I think that's what this question is. So if that wasn't your question, then ask it again and I'll try to answer it.
Okay, I have a few more questions related to the heart. And I do want to reframe the whole calcium discussion, because it's not that we see it a lot in pediatrics, it's that when we see it, we know that there is a scientific reason why it happens, and that we know warfarin does cause systemic calcification. So it's not, by far, it's not like prevalent. But then again, like Lori and I were talking, like we're not looking for it, right? We're not doing CT calcium scores in our other patients with like valves or other reasons to be on Coumadin. So we actually don't know if it's there. But when you do see it on an X-ray that you're doing for a different reason, it's just so, I don't know, it's very striking. And so I can say that it can happen in kids, but it's not like, we don't not use Coumadin when Coumadin's the only medicine that's been shown to be effective like in these valves. So Coumadin is an important medicine. My daughter had leaky capillary syndrome with Kawasaki disease and had leaky valves on echocardiogram and a very pronounced gallop during the acute phase of the illness. Her rheumatologist told me to get a follow-up echo every 5 years, but her cardiologist said no further follow-up is necessary. Do you know if current research supports needing an echo every 5 years? That's a great question. So it sounds like your daughter had KD shock, potentially, leaky valves, and maybe some weak heart muscle. A gallop is very common in the acute phase of Kawasaki disease and actually can be commonly heard in a lot of febrile illnesses. Well, a gallop is a fourth heart sound that we hear, because when your metabolic rate is super high and such, particularly, like I said, in many febrile illnesses, you can hear this fourth heart sound because your heart is like working hard. We're asking your heart to do a lot of work. And so we can hear gallops, but it's commonly heard. I think you guys hear it a lot in Kawasaki disease. In any event, an echocardiogram may not be the best test to do every 5 years, but I do think that in situations where there might have been a lot of capillary leak and potentially KD shock, I don't know if your daughter had decreased function, that this is the patient that we are currently studying with MRIs. So one cardiac MRI, like in adolescence or early adulthood, would be very telling, because what you're looking for is you're looking from scar that might have resulted from the inflammation or the edema in the wall of the heart muscle. So normal, if your echocardiogram is normal in terms of function, great, then perhaps a screening echocardiogram is not necessary. But around adolescence, early adulthood, in this patient, we would order a cardiac MRI to rule out fibrosis or scarring in the heart. It's a good question. I know Boston Children's sometimes recommends a medication that when taken for blood thinning is very effective, but in the case of bleeding from injury can only be stopped by giving another medication at another children's hospital. Is that apixaban? Why does Rady like apixaban, and do other cardiologists know about apixaban for the management of giant aneurysms? My 2-year-old with 3 aneurysms is on Lovenox, aspirin, and beta blocker. Is apixaban only for older kids? Another great question. So all of these systemic anticoagulants that we use, including Lovenox, warfarin, and apixaban and like medications, all of them require reversal agents in the setting of trauma or, some very significant joint swelling, head trauma, things like that. Reversal agents can only be obtained in hospitals, so they're not out there in the pharmacy because they're normally IV continuous infusions of medication to reverse the anticoagulation. In the case of apixaban, in the beginning, there wasn't a good reversal agent, which is why it wasn't widely adopted initially. And then when the pharmaceutical companies made a reversal agent, which I think is called Endexa. I don't know what the other term is, but Endexa is the reversal agent for these DOACs. Endexa wasn't widely available in the beginning. Now Endexa is available. In fact, I called Rady's pharmacy the other month to find out how available it is, because we were considering putting a toddler on apixaban, switching from Lovenox. And Rady Children's Hospital carries Endexa in the need of an emergency, and I imagine so does the big universities now, because DOACs are widely used in adulthood. So reversal agents are absolutely important. It's important to know where you can get them. Particularly with apixaban, you need to know if your local children's hospital carries it, if your child is going to be on a DOAC. We have currently, I think I just presented 24 patients with apixaban. 4 of them are pediatric patients. The youngest age was 4, but last month we did transition one of our giant aneurysm patients at 2 to apixaban. It hasn't been used in patients under 1. Is that right, Dr. Burns? I think apixaban hasn't been used in patients under 1 year of age. I don't know, in the pediatric trial. The trial's coming out called the saxophone study. Might have been 6 months. I don't know what the lower limit is, but we do now have a toddler on it. But the main thing is that if your 3-year-old is going to potentially switch to apixaban, make sure that your local hospital has the reversal agent. That's my recommendation. We like DOACs because they are orally given, so we're not giving the children shots like Lovenox twice a day, although we do have one patient on Lovenox because it works for her and she's okay with it. But families like it because they're not chasing around their children trying to give them injections twice a day. So that's the reason to not be on Lovenox long term, because it's hard in children. We like DOACs better than warfarin because warfarin is very hard to manage in children. There is a very narrow therapeutic range that we need to get the children at, and there was one study out of Boston that showed that only 50% of the time are the patients ever in that range. So we don't think that warfarin is likely a very effective medication, although obviously it's better than nothing. But we think that DOACs are going to be more effective because the level of anticoagulation is more consistent over time. And the last question is it possible to share the name of an adult cardiologist who is knowledgeable about Kawasaki disease in the Delaware area? That is a very specific question. I guess I would you could always call the close by areas with big heart institutes like, I don't know, Johns Hopkins in Boston, and you could try to see if somebody has a resource. I'm sure that you could call the Kawasaki Center at Boston Children's and ask them about Delaware because they're probably closer geographically. I don't know of one personally. I don't know if you guys know of one. Roberta DiBiase at National Children's in DC. Okay, so Roberta DiBiase at National Children's in DC could ask there, and then you also could call Boston Children's and ask. They have a big network of people that they work with.
There's a question about the relationship between KD and mental issues. We gratefully have no reason to think that there's any causality between Kawasaki disease and any mental or developmental issues in our patients. Dr. Daniels shared her data with the adult KD study, and we're still very interested in having anyone out there join that study to be able to tell associations between KD and other diseases. But in terms of causing any developmental issues, we gratefully don't think there's anything with KD.
So there's a question about large aneurysms getting smaller over time as the child gets older, and is it dangerous that it changes in size? And maybe Dr. Drummer would like to answer that.
Wait, getting larger, I'm sorry.
Large aneurysm that gets smaller.
Oh.
Is that good or bad?
Oh, yes. So, that is called regression or remodeling of the aneurysm. And so that does and can happen. It doesn't happen in everybody. Sometimes the aneurysms stay pretty static, which means it doesn't change. But the way that they remodel is by layering down clot basically on the side of the wall called mural thrombus. And then over time, what happens is you kind of grow your own, I say skin, but it's not skin. You grow your own endothelium, so the lining of the vessel kind of becomes new. And so you have old clot that takes up part of that aneurysm, and then you have new lining of a vessel. And so that's actually called remodeling. And remodeling, is a good thing because then you don't have big aneurysms. But the remodeling process can take time and also needs to be supported by our medications as it's remodeling to make sure that the blood is thin going through it. And we do believe that statins can keep those vessels healthy. So I would say, yes, remodeling is a good thing. The bad thing is when it remodels or scars to the point where it's narrow then. And that's always something that, we worry about. But once your vessels have kind of remodeled or are static, typically we don't see further stenosis like decades later. But we do have patients that have stenosis and aneurysms as a result of what they were able to remodel and what they weren't able to remodel. And those patients with narrowing and aneurysms are actually some of the most worrisome patients.
So there's an interesting question here talking about the persistence of virus in adults who died with COVID-19 disease. So COVID-19 is the acute infection with the SARS-CoV-2 virus. And this person is wondering whether persistence of the virus could also be a factor in the patients who have MIS-C. So there's, we actually just addressed this with a conference with the NIH yesterday with Chisato Shimizu in our research group who is looking at this question. There is vast amounts of misinformation and probably errors in publications out there that claim that there is persistence of the spike protein. This is the outer part of the virus. You know, you've seen pictures of the virus and it looks like it has a crown on its head, right, with these little spikes coming out. And that there's persistence of the protein, this spike protein, in patients who have MIS-C. We found that that was not true when we tried to look at it, and there's been a recent paper out of Boston with a very sensitive assay that seems to be very well done that also finds that that is not true. And we are actually working with the group at Columbia that has a very, very sensitive technique for sequencing viruses in your bloodstream. You may not know it, but everybody in this room has viruses right now at this moment circulating in your bloodstream. They're called anelloviruses, they're called tenoviruses. There is a whole community of viruses that we have circulating in our blood, and they're just part of our microbiome. I'm sure you've heard that word. And we have a virome. But this group that we work with at Columbia University, Ian Lipkin and Nishay Mishra, have a very sensitive way of looking for the virus, and we are hoping to be funded by the NIH to actually look at that in our the acute blood samples from our MIS-C patients. I might add, I don't think we've said this today, but MIS-C seems to have disappeared, which we're really happy about because Audrey and I are the two people who have to take care of those patients. And there's been one since May, one MIS-C patient. So we conclude, or we suppose, yeah, right, touch wood. We hope that the current Omicron strains that are circulating are just too wimpy to trigger MIS-C, and maybe it's a huge clue because most of the mutations, the differences in the current circulating strains have to do with that spike protein, that those little knobs that come out of the virus body, and mutations in that, and maybe those mutations are making that virus not able to cause MIS-C.
There's a question here. My adult daughter had KD and transient coronary artery dilation with KD at 4 to 5 years. She's well, and exercise stress test, echo, and 24-hour ECG, all good. Does she need more investigation or follow-up past age 30? So this is a great question. I didn't get into this in my talk about kids who had transient coronary artery dilation. That means the arteries got a little bit wider and then back to normal. We do have some data on that. The numbers aren't quite as big. But if anything, at the moment, that looks more promising. It may be that kids who had transient dilation, some of our testing showed that they may have a healthier vasculature, and that's part of the reason why they rebounded so quickly. We did some testing of the blood vessels, and it was a small number who had the transient dilation, but those who did actually had really good function. So the fact that she's doing well at this time with all these normal tests, I think that's a really good sign, and most likely can be put into the normal category without worry, I would say. The numbers just are too small to be definitive about that, but it looks quite good.
This one asks about the aorta. So have you seen any effect on the aorta after atypical Kawasaki disease? Echoes after my daughter's Kawasaki illness in 2018 at age 6 months found no aneurysms but mild dilation of the ascending aorta. It was suggested that it was unrelated, but I am curious if others have seen aortic involvement. So we have seen transient dilation of various vessels, like including the main pulmonary artery and the aorta during Kawasaki disease. But to be honest with you, we see, random dilation of aortas in normal children who come to us for many different reasons, I have to say. So we see that, if we're doing an echocardiogram, maybe for a murmur or chest pain or fainting, like these typical indications for a screening ultrasound can come back with mild dilation of the aorta. And it doesn't have to mean something scary or even necessarily important. What we usually do is follow them up like a couple years later. And what happens is that as the body grows, often the body grows into the size of the aorta. So the relative dilation that you see when babies are little can often go away and disappear unless there's some underlying genetic reason why the aorta is dilated. But the vast majority of time, these mild dilation of these great arteries actually goes away as the body grows faster than the vessel. So that's what I would say about that.
So I think we've got a couple more questions left. One of them is about the correlation between KD and autoimmune family history. We really don't see an association there that commonly happens in our children with Kawasaki disease. That said, another reason for people to join the adult study and be able to provide more data for us so that we can look for those correlations there. But thus far, as Dr. Burns pointed out, the main thing is that some children are at a higher risk of eczema, but not in terms of autoimmune disorders. And there's also a question about what happens with your donated samples, how the feedback comes to you. We really do this session, and we've been doing it for the last, I think Dr. Burns pointed out, like 14 years. Really, this is our chance to tell you what's happened with a lot of the samples that you guys have provided. Dr. Burns likes to say that we're not a savings bank in terms of samples. We're here to grab samples from our families, put them to use, and then put that back into the clinical care of our patients. And that's exactly right, that while we do have freezers in our lab, we're constantly working on using those samples. So if you got to our emergency room and you donated samples before your child was treated, that's what the data that then went to someone like Jonathan in terms of the decision support tool development. If you were in one of our clinical trials for the treatments, those are the data that we presented today, and the same with the genetic work. So we hope that this provides some closure to that loop for those families that have been involved in our studies, and we encourage you to keep doing that.
So I think we're done, and thank you to everybody in person, online, everywhere for participating. Thank you to the KD Foundation, and a huge shout out to Amelia Bainto in our research group, who really takes this on as her main task and organizes everybody, and Chisato and Koichi, who put out signs, and it takes a lot to put this on, and we're really grateful to all of our team who participated in that. And thank you all for coming. Have a great rest of your Saturday.